course director, Dr. Murthy sir, or respected faculties, moderators, speakers, as well as the all the respected delegates on this virtual program of ADA 2024. It's Corona's perspective to take the science to the next level. So this entire program from Corona Remedies, I invite Dr. Amit Bhargava. Dr. Amit Bhargava is associated with Corona Remedies recently. He is currently heading the medical department of Corona Remedies. He is also director for one of the research association body which he has made called HARD. He was the ex-board member also at medical faculty MUHS Pune. He has done his MBBS as well as MD in medicine, and he has a very rich experience of 36 plus years in the field of teaching, research, IT industry. He is also practicing. He has been associated with various pharma industry also, and he has more than 31 publications, 10 conferences, presentations, and he has also conducted more than 200 CMEs and ad board meeting across his career. So I request Dr. Amit Bhargava to take the program forward. Please, sir.
Thank you very much, Mr. Jayesh. Can I get the screen to share?
Dr. Murthy.
No. I have my presentation. I told you there are 3-4 slides. So a very warm welcome to all of you on a Sunday morning. And I know how precious Sundays are, and yet you are here. So thank you all very much. I'm not going to stand between you and these wonderful ADA proceedings. But we just want to highlight something about why Corona is spending time and effort on organizing these meetings. You have all been through the ADA proceedings. So, you might be wondering, so what is Corona going to do for us? Well, it's all about clinical practice, the concept of clinical reasoning, and most importantly, clinical experience. We are all familiar with this professional lifespan spectrum. We have all been students. We have acquired knowledge. We have become professionals. We have practiced. We have become successful. I mean, each one of you viewing this program is a successful clinician. And now comes the punch. The exceptional clinical experiences that some people have got makes them an expert. So there is a need for experts to share their exceptional clinical experiences to enhance the clinical outcomes in everybody's clinical practice. So there is a lot to be learned from the experience of these experts. So now I'm sure you know what this theme is all about. It's all about experience and the importance that it plays in clinical practice. This is the clinical practice spectrum. What I'm going to show you, you might very well say, what nonsense is Dr. Bhargav talking? But it's not nonsense. This is what I have understood, and I am absolutely sure and quite capable of debating on this also later, that RCTs and guidelines are just clinical evidence. They are not enough for clinical practice. What is required for clinical practice is the concept of clinical reasoning. So what is clinical reasoning? Way back in 2013, Professor Schneiderman at Mayo Clinics, he wrote a very beautiful review article on this topic, the necessity of clinical reasoning in the era of evidence-based medicine. Evidence is not enough. These are all the sources of evidences that we rely on to decide what to adopt and what not to adopt in clinical practice. You have guidelines, RCTs, reviews, observation, open observational studies, investigator-initiated studies, whatever it is. But on top of that, we need mechanistic reasoning. What exactly is happening to that single patient sitting across the table? And most importantly, clinical experience, which only comes with time. There is no shortcut to it. There is no course in any medical school anywhere in the world which teaches you that. And this entire gamut is what is referred to as clinical reasoning, which is required for clinical practice. So all these guidelines and everything, they are accessible in the public domain. They're static entities. They don't change with time. They're contrived because of the way that people either develop clinical trials or develop guidelines. We have to use our own judgment. And this clinical experience, however, is a unique, intrinsic, integral, dynamic part of each clinical expert, not easily accessible or disseminated because of paucity of time. So this is what Corona is facilitating by taking the entire ADA proceedings and inviting these renowned experts. Each speaker is a renowned person in their own specialty. And finally, setting the equation, clinical evidence, which is very important. I'm not saying it's not important, plus clinical experience. That is what makes a clinical expert. So without any more ado, I would like to invite the clinical expert, one of the greatest clinical experts in the field of endocrinology, Dr. S. Murthy, Chennai. He is Director, Diabetes Care Center, Consultant Endocrinologist at Department of Neurosurgery.
Sorry to interrupt. I will just appreciate just a one-line introduction.
Okay, sir. So it's extremely brief, and I will speed it up very quickly. These are his educational qualification, all from the famous MMC, Madras Medical College, and PGI Chandigarh. These are his past positions, and as you can see, I mean, he has done just about everything from teaching to hosting, initiating Andropause Society of India, conducting conferences, etc. And the significant achievements, I mean, there's a whole list in a CV, but here I've summarized some really important ones. Set up the first hormone assay lab, a lot of clinical trials on all these molecules listed here. And he's the faculty pass, obviously, he's a faculty and a participant in numerous international and national conferences. So it is my privilege to invite you, sir. The floor is all yours. I stop sharing my slide.
Thank you very much, Dr. Amit Bhargav, for those kind words. And a big thank you to Mr. Vijay Charlu, Mr. Jayesh Vas, and the Corona team for inviting me to this exciting meeting, the fourth ADA Deciphering Indian Perspective meeting in the Indian context, a meeting where you brought together a galaxy of eminent endocrinologists, cardiologists, and nephrologists to the same platform, each an authority in their individual fields, to discuss a few topics of interest to the Indian scenario from a whole list of talks which were delivered in ADA 2024. To set this in context, the meeting, we have 3 modules. Each module will have a moderator and 3 talks, each of 15 minutes each, followed by another 15 minutes of discussion. And at the end of the talk, all the 3 talks, the 3 modules are over. I'll come in for a summary and synopsis. To start the proceedings, may I now request, could I have Dr. Ameya Joshi's CV? May I now invite Dr. Ameya Joshi, an eminent this generation endocrinologist, is Director Diabetes and Endocrine Clinic, Mumbai, consultant in charge of various hospitals and research center, recipient of IDF and European Society of Endocrinology and Hinks grant, past secretary, Maharashtra Endocrine Society, scientific secretary, SECON 2019. Dr. Ameya Joshi, the floor is yours to start the proceedings on the first module.
Thank you, Dr. Murthy sir, and very good morning to all. It's always a treat to meet with all the experts, and I think I must express my gratitude to Corona Remedies for conducting this program on a regular basis and also inviting me to be a part of this. What we learned in the Corona era, I would say COVID, post-COVID era, is that virtual interactions are an important source of gaining knowledge. I must say, I learned so much of endocrinology after this virtual knowledge boomed, and it became possible to attend mega events virtually, to deliberate on mega events virtually, like we are doing today. And the ultimate beneficiary has to be the patients to whom the benefit is passed by the treating doctors. And I'm sure all my colleagues who are listening to this program will benefit from this. We all knew that diabetes is the root cause or risk factor for heart failure, coronary artery disease, renal problems. However, not a single medication up till a decade ago, which was used to treat diabetes, could actually treat the complications of diabetes, most notably the cardiorenal complications. The spectrum or this thought process changed after SGLT2 inhibitors and GLP-1 receptor agonists, which actually came up as anti-diabetics but stood out as cardio-reno-protective molecules to an extent that they were and are being explored as a possible treatment for renal and cardiac elements in people without diabetes and coming out successfully in whatever trials that have been done till date for these indications also. And so they have been identified as cardio-renoprotective molecules, which also help in lowering the blood glucose levels. Now being prescribed by endocrinologist, cardiologist, nephrologist, ultimately benefiting the patients. It is my utmost pleasure to introduce our first speaker, Dr. Subhash Chandra sir. Can I have the CV of sir, please? Dr. Subhash Chandra sir is Chairman and Head Department of Cardiology, BLK Center for Cardiac Sciences, New Delhi, and Director of Interventional Cardiology, Fortis Heart Institute. In the past, he has been consultant at Indraprastha Apollo Hospital and Cath Lab at Narendra Mohan Hospital. Sir has been Associate Professor of Cardiology at prestigious All India Institute of Medical Sciences, New Delhi, with more than 25 years of experience in performing large variety of interventional procedures. Sir has been recipient of Sujoy B. Roy Young Investigator Award from CSI, with more than a century of publications in indexed national and international journals. Sir will be taking us through an interesting topic of a trial related to an originally anti-diabetic medication called as semaglutide, which has been a revolution. You don't actually need to prescribe semaglutide now to a patients. Many times patients take it on their own and come to a doctor only when they have some complications. It's so popular on Twitter and social media, so on and so forth. But it's a molecule par excellence in terms of cardio and renal protection. And we'll be discussing a select trial of semaglutide, which will give us glimpses about the new look at glycemia, inflammation, and heart failure.
Thanks.
Over to you, Dr. Subhash Chandra sir.
Thank you. Can I upload my slides? Are they visible?
Yes, sir.
All right. Thanks so much. And I'm glad that as a cardiologist, I'm participating in this forum, which is full of very eminent endocrinologists. And I always look forward to learn from them. Nevertheless, as far as the cardiology part is concerned, I'll just apprise you about one very important trial which was presented recently in ADA in December 23. So this was a trial on a novel GLP-1 analog, which is semaglutide injectable, in which it was looking at a new look at glycemia, body weight, and heart failure. So just an overview, and then thereafter I'll apprise you whatever little I have learned about this trial, but I'll look forward to learn from the experts who are here as to how this molecule works in the space of reducing cardiovascular events in patients who are obese and yet not proven diabetic, which is a very, very peculiar and very largely existing subset in our population. So we know in the background that GLP-1 analog semaglutide has been prescribed for more than a decade now in diabetic population, largely for its benefit on MACE and the renal benefits. And it does reduce weight also in the process. And it is a wonderful molecule in tandem with SGLT2 inhibitors, which also have been established as a MACE reducing, heart failure reducing, or renal dysfunction reducing molecules in the domain of diabetes. So let's focus on GLP-1 analog, that how does it work? It works in different mechanisms, whereas it has a cardioprotective effect. It does act on platelets, just reducing coagulation. It has postprandial lipid reduction qualities. In kidneys, it causes natriuresis and diuresis, thus can help the heart failure patients. It does reduce blood pressure to some extent. Body weight reduction through various brain mechanisms is the most prominent effect of this molecule. It reduces inflammation, and that is how it helps in reducing MACE also. And of course, it controls hyperglycemia through different mechanisms in which reducing insulin and reducing glucagon production of liver glucose is one of the important action of this molecule. The rationale for this trial was that the impact of glycemia on the MACE is prominent, where if you leave diabetes uncontrolled, it leads to increased cardiovascular, cerebrovascular, peripheral vascular events. And this trial is peculiar in the sense that you're not recruiting diabetic patients, but you're recruiting obese and overweight patients, which in itself is an inherent risk factor for cardiovascular disease. And to test this molecule in a higher dose than usual of 2.4 milligram weekly, and tested for over 3 years in almost 41 countries. We are looking at the individuals with obesity and high cardiovascular risk. That means patients with established cardiovascular disease, but without established diabetes. In fact, about two-thirds of these patients were pre-diabetic, whereby HbA1c was between 5.7 to 6.2, and the rest had normal glycemia. And we were looking at the cardiac endpoints in the terms of MACE, which is cardiac death, non-fatal MI, non-fatal strokes, and peripheral vascular disease. So it was mediated by weight loss, mediated by semaglutide addition, where a lot of pleiotropic effects of semaglutide could come handy, and of course cardiovascular event reduction. So SELECT was not a weight loss trial, but it was a heart disease prevention trial that, besides the lifestyle modification or control of blood pressure and lipids, can weight reduction by this molecule lead to reduction in MACE in patients who have established cardiovascular disease. So this was the design of the study, in which people who were obese, BMI of more than 27, with established cardiovascular disease and no prior diabetes. Some of measurements of HbA1c were used to determine glycemic status. So we had no clue as to over a time period where is the HbA1c going. And about a quarter of participants in each arm discontinued their randomized treatment, and any legacy effect of semaglutide after withdrawal of the intervention were not examined. So with that, I submit and conclude that semaglutide positively impacts the progression of diabetes and regression of normoglycemia in people with prediabetes, and thus in people with overweight and obesity and cardiovascular disease. Treatment with semaglutide would be expected to positively impact glycemia in addition to CV outcomes. Thank you very much.
Thank you, Dr. Subhash Chandra sir, for the wonderful, crisp, to the point deliberation of a clinical trial. I would request you to stay back with us because at the end of session 1, after finishing the 3 talks, we will be having question and answers. I would request all the delegates who have joined, if they have any queries, questions, or comments to be made, request to make them in the chat box so that they can be forwarded to the moderator and can be taken up for discussion after all the 3 talks in session 1 are over. As we switch gears, it gives me a great pleasure to introduce my good friend and a reputed endocrinologist from Kolkata, Dr. Rana Bhattacharjee. I think Dr. Rana is a popular speaker not only in West Bengal but across India. He is a consultant endocrinologist at Midland Clinic at Sham Bazar area of Calcutta.
I think you can skip this. This is an outdated and kind of business CV slide. I don't know where it has come from.
Has
You can skip this, Ameya.
teaching has past teaching positions, and I mean a very popular speaker, known academician. His articles are quoted very often, and also the messages that he always conveys are simple and crisp. He will be taking us through a very important topic, a topic that has been path-breaking in last 5 to 7 years, I must say, about how to approach a newly diagnosed type 2 diabetes patient. What should be the focus of management? Should it be, in simple words, glycemic control, end organ protection, or somewhere a combination of two? Over to you, Dr. Rana.
Thank you, Ameya, so much for this kind introduction. Can I have the, can you just unshare it? Thank you so much. Let me share mine. Hope it is clearly visible. A very good morning to all of you and all those eminent faculties, those who are present here and those who have joined in this very early morning to listen to this on a Sunday. So, as you know, the newly diagnosed type 2 diabetes is an excellent opportunity to treat and prevent many of the complications that are associated with diabetes. Not only that, a newly diagnosed type 2 diabetes patient also serves as an opportunity to identify the associated comorbidities that can be treated early, like hypertension or dyslipidemia, which could have been remain unrecognized otherwise. So the whole spectrum of how to approach to a newly diagnosed type 2 diabetes patient is not the focus of discussion today. I would rather focus on 2 different aspects of management of newly diagnosed diabetes that has been discussed in ADA, and those 2 are, number 1 is obesity, and number 2, how the early approach in controlling hyperglycemia can prevent long-term complication. So let's start with the first one, the obesity. We all know that obesity is associated with lots and lots of comorbidities and complication. And of course, it includes type 2 diabetes. And in ADA this year, a lot of focus was on this particular aspect of type 2 diabetes. Now, not only the obesity associated with type 2 diabetes, but also a person who does not have diabetes but have obesity. To treat obesity, we can prevent these complications, including type 2 diabetes. Now, there are various anti-obesity medications that are available to us. However, in India, we have a very limited option. If we talk about an exclusive anti-obesity drug, that the only one that is available is orlistat. And if we talk about the drugs which can be considered as anti-diabetic medication and anti-obesity medication, there are a few which can be considered as both, and that include mainly GLP-1 receptor agonist and maybe SGLT inhibitor to some extent. But we all know that the weight loss that has been achieved with SGLT inhibitor tend to wane off after a certain period of time. Fortunately, now we are having lots of therapy. We'll just focus on few of those, like a combined GIP and GLP-1 receptor agonist as well. So when we talk about the weight reduction and its benefit, so the degree of weight reduction, it's extremely important. Like 5% weight loss leads to improvement in hyperglycemia as well as hypertension. And a further weight loss in the extent of around 10% can also prevent and mitigate other conditions like PCOS and NAFLD as well as GERD, gastrointestinal reflux disease, gastroesophageal reflux disease. Further reduction of weight can lead to improvement in osteoarthritis of knee unless it's very advanced, as well as the complications like obstructive sleep apnea and stress urinary incontinence. And more than 50% weight loss, as we have seen in many trials, particularly in the early stages of diabetes, lead to remission of type 2 diabetes. Plus, it has been shown its beneficial effect in heart failure with preserved ejection fraction. Now, the drugs that are available to us, if we talk about the magnitude of weight reduction which can be achieved by each of those, we'll focus on the orlistat because, as I've discussed, this is the only exclusive anti-obesity drug that is available to us in India. And less than 5% on an average is the weight loss that can be achieved with this drug. This doesn't mean that the 5% is a maximum limit. There are some patients which can lose even more. But overall, what we found that it's not a very kind of extremely effective anti-obesity agent. Whereas the other drugs like phentermine or naltrexone, bupropion, or a combination of phentermine, topiramate, all those are not available to us. However, in US, the liraglutide 3 milligram has shown to reduce the body weight around 10%, just less than that. Semaglutide has already been discussed by Dr. Subhash Chandra, and the weight loss is more remarkable, particularly with 2.4 milligram, which is the anti-obesity dose, which is beyond the standard anti-diabetic dose that is used. And with tirzepatide, the dual GLP-1 and GIP agonist leads to further weight loss. And in this context, I would add that even the more recent evidence has suggested that the triple agonist, where there is a glucagon agonism in addition to this GLP-1 and GIP, the drugs like retatrutide can give rise to more than 25% weight loss in about 1/4 of our patients. So the horizon of the anti-obesity medication, which can be called as nutrient-stimulated hormone-based therapies, because basically they use the agonism property of an indigenous molecules. Those are associated with the food intake. In short, we call them incretin-based therapies as well. So we discussed many of those trials. We'll discuss even a few. The semaglutide, as I've said, already been discussed. Tirzepatide has already been approved for obesity, and India hopefully will get this molecule for use within a few months, maybe. There are other drugs like the combination of cagrilintide and semaglutide, that is CagriSema, which is in phase 3 now, which has also shown promise. The other drugs like survodutide is also under evaluation. Retatrutide I have already discussed, and orforglipron is a molecule which is kind of orally administered GLP-1 agonist like semaglutide oral to some extent, although there are some molecular differences. It is a non-peptide molecule. And other gliprons like danuglipron is also under development. So there are lots and lots of molecules that are coming up for the management of obesity. Regarding semaglutide, I think select trials has already been discussed by Dr. Subhash Chandra. I won't go into that. STEP-HFA program is again from the cardiologic perspective. The patients with obesity without type 2 diabetes, there is significant reduction of heart failure related symptoms. I won't go into detail of that. Recently concluded FLOW trial, which has been published in NAGM just around 2-3 months back. This is also another very interesting trial, which is a first city which showed that the semaglutide is associated with a significant reduction of risk of kidney disease progression and associated CV event. So it prevented hard renal outcome, which is very important because among anti-obesity drugs, we knew that SGLT2 inhibitor had this kind of effect, but now we have an evidence that GLP-1 agonists can have this effect, particularly semaglutide. Regarding the body weight change, again, I won't go into detail of this because you can see here in the chart that in comparison to placebo, there is a significant reduction of body weight, mean body weight loss around 13 to 14% in arm of patients who use semaglutide. Now, I touched upon tirzepatide, the dual agonist, and as you can see here, this is the placebo arm, and this is the tirzepatide 15 milligrams arm, which is the maximally prescribed dose as of now, and it has shown more than 20% reduction of baseline body weight. And not only that, there are some surrogate improvement, like SURMOUNT-OSA, that trial which has been published has shown a significant reduction of apnea-hypopnea index within weeks of starting using this medication. And SURMOUNT-MMO is a trial which is still ongoing. It actually focuses again on patients with OSA, but that this trial will look at the improvement of cardiovascular morbidity and mortality in addition to improvement of OSA. Now, whenever we talk about these drugs which leads to improvement in glycemic status and body weight, we must remember the adherence to therapy is extremely important. Many of our patients ask that whether we can use this drug, as those drugs are expensive, we can use these drugs for a short period of time. The answer is clearly no, because times and again it has been shown in all those trials, the patients who defaulted, there is a worsening of both the glycemic status as well as the body weight. So there is a weight regain as well as worsening of glycemic status with time once the medicines are discontinued. But of course, just like any field of medicines, there are a few exceptions. There are some patients who can continue with intensive lifestyle changes and they can maintain their body weight. But again, those are exceptions rather than rules. So you need to continue with the therapy, and that is the evidence now. So among the diabetes care, we had all these targets. We can add obesity in addition to that. The second and part of my discussion, as I've said, is the management, the early management of diabetes and prevention of complications. Now, we now have a person-based management of type 2 diabetes, and the early management is extremely important because more intensive is the treatment, avoiding hypoglycemia, of course, more the benefit in terms of long-term adverse events. And we know this is known as legacy effect, and this has been first demonstrated in UKPDS, despite many flaws in this particular trial, because it's the early days of trial regarding anti-diabetic drugs, but still this landmark trial showed us that during the period of 10 years of this trial, there are improvement in terms of microvascular outcomes, and during the follow-up for another 10 years, when the A1C became equivalent, still there is a benefit in terms of microvascular outcome. In addition, there is a benefit of cardiovascular outcome in the long run as well. On the other hand, the trials like Advance, which recruited patients with a cardiovascular disease risk factor to begin with, and has already significant duration of diabetes when they were recruited, it has been shown during that trial period there was not much benefit neither in terms of micro or macrovascular outcome, except possibly as a secondary outcome, the end-stage renal disease reduction. And the similar result also was shown in the follow-up period of these trials. So what does it mean? It means that the early treatment and intensive treatment of hyperglycemia leads to significant reduction of microvascular as well as macrovascular complications in the long run. And now we have drugs like SGLT2 inhibitors. It has been shown that the patients who has underlying heart failure or CVD can have a long-term benefit. In addition to that is achieved by glycemic control. And not only hyperglycemia, but also the control of blood pressure and lipid is extremely important, because the trial like Steno-2, which is a extremely well-conducted trial, and the long-term follow-up is still ongoing. And it has been shown that the early multi-prong targeting many aspects of the diabetes and its comorbidities leads to long-term improvement in terms of improvement in retinopathy, improvement in autonomic neuropathy, and improvement in renal outcomes as well. So not only hyperglycemia, but early management of diabetes should focus on associated comorbidities like dyslipidemia and hypertension as well. Another aspect of early intensive treatment is that which we saw in Verified trial, which has been published a few years back, which showed that the initial aggressive therapy with agents that are less likely to cause hypoglycemia in individuals who have a relatively better glycemic status to begin with, the average A1C between 6.5 to 7.5, that leads to the long-term preservation of beta cells, because the treatment failures occur later in the group who received the combination therapy of vildagliptin and metformin to begin with. So we know the management of diabetes has become increasingly complex, but it is becoming increasingly satisfying as well, because now we have various drugs, various modalities by which we can treat not only the hyperglycemia itself, but also the various complications associated with it. So in the very beginning, we should focus on multiple complications and in view of future prevention of various complications. Thank you for your patient listening. Over to our respected moderator for further proceedings. Thank you.
Thank you, Dr. Rana, for the wonderful talk. I think you very clearly highlighted an increasing job for an endocrinologist to do more and more risk stratification on day one. Earlier, it was like a person coming to the OPD with high glucose used to be given some medication, and then, okay, next visit you can do some tests and come back. I think it is very important that on day one, the person with diabetes is given a proper attention, stratifying the risk and approached in a holistic manner. As Dr. Rana said, with an evidence. Thank you for the talk, and do stay back with us for the Q&A session, which will be after the next talk. for which it's my pleasure to introduce Dr. Sree Bhushan Raju. Sir is a professor and head department of nephrology at Nizam Institute of Medical Sciences and has been on editorial board of several journals, including Indian Journal of Nephrology, has been an organizing secretary of IonCon and ISOTCon, more than 100 publications with 7 Best Paper Awards, and one of the principal investigators of CKD Task Force by ICMR, reviewer for several journals and a mentor for several young nephrologists. Dr. Raju will be discussing about acute kidney injury and its long-term consequences in the treatment of diabetes. We always see nephrologists advise, avoid this, and most of that is meant to slow down or reduce the chances of acceleration of the CKD. I must say diabetes is a background CKD in itself. So I think it's very important of an early nephrology referral also. It's over to you, Dr. Sree Bhushan Raju.
Good morning, everyone. And thank you very much for giving me this opportunity to speak in front of senior colleagues of our specialties. And I thank Corona Remedies also for organizing this wonderful meeting early in the morning on Sundays, where usually we know that in the human body, the organs will have a crosstalk. And occasionally specialty doctors also should have a crosstalk so that they can learn from each other. And of course, it's a mutual learning process for everyone. And we learned a lot from the diabetologists and the endocrinologists and the cardiologists, and the diabetes being the leading cause of chronic kidney disease and end-stage renal disease across the world, more so in our country, where it is the diabetes capital in the world. And we know that most of the patients admitted into the intensive care, they develop acute kidney injury, which significantly contributes to the mortality and morbidity. Not only that, even in the outpatient clinic, we try to see some of the patients where the sudden deterioration will certainly takes place, and over a period of time, they slowly come back to us with their established chronic kidney disease over a period of time. And we try to elucidate what could be the reason for that. And we find a lot of clinical situations where the patients would be taking so many drugs, that whatever maybe either it's an SGLT2 inhibitors or any antibiotics, the NSAIDs and the proton pump inhibitors, where they can lead to acute kidney injury, and they slowly develop chronic kidney disease over a period of time. And the diabetes is the most common cause of underlying etiology for them to make them more vulnerable to develop acute kidney injury. And these are the patients who have got unique characteristic features of the kidney, which makes them vulnerable for acute kidney injury with a consequent chronic kidney disease. Today, I would like to speak a little bit about the acute kidney injury, the conundrum, which ultimately becomes chronic kidney disease and end-stage renal disease in our group of people. Diabetic patients, because of their unique characteristics which are taking place histopathologically within the organ, are more vulnerable. There are several microvascular complications that take place in the kidney. And one such thing, several associated features like coronary artery disease, peripheral vascular disease, and strokes, the major micro and macrovascular complications, all of them put together, they come to the hospital and they will be having multiple drugs, therapies of various reasons and various indications, and which makes them vulnerable for acute kidney injury. And for the past several decades, there is so much of a change in the management of patients with acute kidney injury. But unfortunately, the risk of morbidity and mortality did not change. And more than 50% of the patients who are admitted into the intensive care with acute kidney injury, they die of complications. And this number is the same for the past few decades. And we have improved a lot. We have improved with the drug therapies, management of the critically sick patient, and management of dialysis therapies in the form of continuous renal replacement therapy, CRRTs and SLED, and different varieties of absorption technologies in the dialysis management with the filters, and so many other things. And intensive care also has improved over a period of time in taking care of the patient in general. Despite that, the AKI is the same, and the mortality associated with is also the same, around 50% and above that. And we could not really change much. And among them, the diabetic patients are the most important group of people who have highest morbidity and mortality with acute kidney injury. And because of the several complications, they get into the intensive care, and they succumb to the illness where the AKA contributes significantly to their mortality. And we know that the Morganson's classification of the changes over a period of time that takes place within the kidney in patients with the diabetes. But this is classically described with the type 1 diabetes, which not exactly the replicates in patients with the type 2 diabetes. But however, most of the patients with the type 2 diabetes also will have some of the changes which they certainly take place irrespective of the duration of the type diabetes. In type 1 diabetes, we have a duration-based changes in the kidney. That's something like 5 years, 10 years, 15 years, and 20 years, where the glomerular basement membrane thickens, and over a period of time, it leads to ultimately the hyperfiltration, followed by hypofiltration with a microproteinuria, followed by overt proteinuria, leading to the chronic kidney disease changes with established fibrosis of the kidney with a diabetic glomerulosclerosis, leading to end-stage renal disease. But here, even in type 2 diabetes, also similar changes take place initially to start with the onset of type 2 diabetes, where there can be some hyperfiltration initially, where the GFR will go up, then gradually GFR will fall down with the proteinuria from micro to macro to overt nephropathy. And proteinuria is a surrogate marker not only of the kidney dysfunction, but also equally that of coronary artery disease, where they die significantly with the coronary artery disease and its consequent mortality. So our patients are with the proteinuria are more vulnerable for other complications also, which makes them vulnerable again for the kidney injury which takes place with any of them. And this is basically the histopathological changes which take place over a period of time with the hypertrophy, hyperfiltration, and the glomerular disease with any clinical disease, but then incipient nephropathy and overt nephropathy and end-stage renal disease. These are the classical histopathological features in association with the clinical features, and end-stage renal disease is the consequent of that. But interestingly, several of these patients would have had several episodes of acute kidney injury in general, which are many a times subtle, which many a times may not be noticed in a significant way. And unless they get admitted to the hospital and they get treated for that, they get improvement partially or completely sometimes, but very rarely. But partial improvement is also seen in them, and they get into a clinical conundrum called AKA conundrum. Here it is acute kidney injury to start with, and which is defined as the one which where the acute kidney injury persists for less than 7 days. And of course, the definition of acute kidney injury differs, and almost it has been known that more than 36 to 38 definitions are given to AKA. But the three major definition protocols are there for the AKI, and it's more than 50% fall in the GFR in less than 7 days. It is a classic, and in association with the increase in the serum creatinine and oliguria for more than 6 hours. And here it is an AKI is called only when it is persists for less than 7 days. But AKD is the one which persists, the AKA, the kidney injury persisting for more than 7 days to less than 3 months duration is called acute kidney disease. The acute kidney disease is also marked by the fall in GFR, increase in the creatinine, and further continuation of the oliguria or anuria. And when the disease, the kidney disease and the kidney injury persists for more than 3 months, it is called chronic kidney disease, where the persistent fall in GFR by less than 60 ml per minute. And there are several markers of kidney injury which can be detected when it is an AKI, AKD, or CKD. But unfortunately, none of the biomarkers which are known or existing in our current literature are able to clearly and classically depict the ongoing onslaught of injury which is taking place within the kidney, unfortunately. But still, we bank upon the proteinuria, creatinine, urine output, and these are the major three parameters, unfortunately, on which we depend rather than any early marker, something like a biomarker, something like an NGAL, etc., which could not really make any difference either clinically to the clinician or either predicting the prognosis or the therapy otherwise. When it is going to persist for a very, very long time, these patients of CKD progress over a period of time to get into chronic kidney disease. And most of the patients who are admitted into the sickness with AKI in intensive care setup are having diabetes. And most of the patients are vulnerable because of the presence of diabetes itself. The why diabetes makes them more vulnerable, and we cannot really make out any significant differential unique features about AKI affecting the diabetic patients when compared to the non-diabetic patients histopathologically. But clinically, we can make out that these people get an established AKD and CKD later when compared to the non-diabetic AKIs. That's why we have to take care and we have to follow them up for a very, very long time. Even any patient with diabetes gets admitted with AKI. So this is a simple picture which is depicting how the microenvironment within the within the glomerulus and which gets affected, and especially the renal tubular epithelial cells and the podocytes, they transforms themselves into a myofibroblast and fibroblast with the deposition of fibrotic material by the TGF beta and especially expansion of the extracellular material, and which the consequent secretion of several hormones locally, which can really make the environment totally toxic within the kidney and leading to the continuation of the AKI leading to CKD. So these people have more vulnerability and more at risk of developing progressive CKD and renal disease and death compared to those patients without AKI or without type 2 diabetes. But AKI itself in general has got several consequent complications in those patients, and especially the sick patients, even without diabetes. But with diabetes, probably the consequent risk of getting AKD, CKD, SRD, and the mortality gets quadrupled in these kind of patients. So this is a picture depicting how the AKI and gets transformed itself into the CKD with the presence of the release of pro-fibrotic cytokines within the milieu of the kidney, and ultimately leading to an established chronic kidney disease in them. So several studies have been done and how this particular AKI progresses to CKD, and also at the same time how to prevent and how to treat also further. And this is the pathophysiology, which probably I will not be able to discuss much. And as I stated, we have so many biomarkers which can probably predict that these patients are vulnerable to make AKI into chronic kidney disease. The KIM1, NGAL, the TIM2, and IGF-BP7. These are the several markers which have been utilized. Some of these molecules, especially the KIM1, could really make some inroads into our understanding about the pathophysiology of AKI in AKI, especially those with type 2 diabetes. But prognostic marker as such, we could not really develop over a period of time. There are several drugs have been used, especially that in cardiac angiograms, when these people are undergoing, NSL systems have been extensively used. And even now, every cardiologist passionately writes N-acetylcysteine to all the patients undergoing coronary angiogram. But in clinical practice, it could not really make any difference. And several studies, and more than 500, 700 studies which have been published, including our own Indian data, did not really make any difference as far as the prevention of occurrence of AKI or the consequent CKD when the patients were given N-acetylcysteine before the angiogram, or even the coronary cardiac surgery also at the same time. Similarly, the allopurinol, trimetazidine, in preventing the contrast-induced nephropathy and several other drugs could not really make any difference as far as the prevention of contrast-induced nephropathy in these patients. Not only these patients with the contrast-induced, but the several other drugs, especially chemotherapeutic agents like cisplatin and several newer molecules, which really can lead to AKI, were also studied. But unfortunately, we could not get any major molecule at the drug therapy which can prevent the occurrence of AKI. That makes it more important for us to see that the prevention of AKI is more important, and the prediction of AKI is also equally important. And when to give a therapy, when not to give a therapy is also equally important. And rather than trying to prevent the progression later. So prevention is always important in diabetic patients who are vulnerable to develop AKI in either in the OPD setup or in the intensive care setup. So I've been discussing a lot about the intensive care setup, but there are several OPD situations where we can see some of the patients subtly developing AKIs. Now the most talked about the drug is actually SGLT2 inhibitors, and I think it's been already over now. The semaglutide has taken over the discussion part of most of the endocrinologists, cardiologists, nephrologists, and the clinicians as such. But SGLT2 inhibitors can really lead to a subtle change in the GFR with a fall in the GFR. I'm one of the principal investigators of the Credence trial in this country, and where we found that these molecules are wonderful in preventing the progression of the CKD and cardiovascular risk factors, as well as the improvement in the GFR for a very long time. And so we are also equally concerned about this particular molecule and trying to utilize them in association with ACE inhibitors and ARB. Sometimes These drugs are supposed to be given together. You all know that the ACE inhibitors, ARBs are the important molecules for us. We always try to start any diabetic patient or non-diabetic patient with hypertension with ACE inhibitor or ARB. Predominantly the ARBs in the clinical practice. But SGLT2 inhibitors also are supposed to be given to these patients to prevent progression. But unfortunately, some of these patients are vulnerable for development of AKI certainly. That's why when we given a prescription of SGLT2 inhibitor, we should be able to monitor them frequently for the GFR, not only the other markers of sodium, potassium, and other markers, but subtle evidences of dehydration, which has been associated with SGLT2 inhibitors, probably can lead to AKI certainly, and there can be some improvement. So several studies have been done, and to know whether it is really important or not, in those patients in association with the RAS blockade and SGLT2 inhibitors, how many of them are actually at risk? RAS blockade is also vulnerable. You know that the CFR falls down a little bit and the creatinine slightly goes up when you start a patient on ACE inhibitor ARB. And RAS blockade is known to increase the creatinine a bit subtly, but it has been said that those with a slight raise in the creatinine are the beneficiaries ultimately of the ACE inhibitor therapy when you see them after 3 years or 5 years or several years after changing, rather than stopping the drug by looking at the elevated creatinine in the initial phase itself. So better not to stop any ACE inhibitor ARB by looking at the slight raise in the creatinine unless it is more than 30 to 50% and above initially, and then you can stop for a temporary period and restart with a low dose. But if you stop it, probably these people are not going to get benefited out of that. Similarly, associated other drugs like diuretics, SGLT inhibitors probably will make them more vulnerable. And you know that the cardiovascular outcome and the adverse renal outcomes with SGLT2 inhibitors over a period of time are known to get improved by the SGLT2 inhibitors. And these drugs are known to improve that. But the several meta-analyses showed that and reduce the risk of kidney disease by 37%, AKA also by 23% overall when compared to the placebo by these drugs called SGLT2 inhibitors. The overall, the relative risk for the kidney failure in some component of this particular outcome in the CKD trials was 0.67. There is no evidence that the relative risk reduction differed depending on the baseline GFR. The patients with the CKD are more vulnerable to get injured easily when compared to those patients with the non-CKD. That's why, of course, we see even without any kidney injury initially to start with, also are vulnerable for AKI that we see with the contrast-induced nephropathy in ICCUs. But still, CKD underlying subtle fall in the GFR initially makes them more vulnerable for development AKI. That's why patient already is a established CKD. Be careful in using them. And if at all you have to use SGLT2 inhibitor, we need to monitor them frequently so that it will not adversely affect the kidney outcome initially, at least in the initial period. And several drugs have been used in concurrently. And my thing is actually not about preventing the people from writing SGLT2 inhibitors or any other drug, but concurrent medications have to be taken care properly, especially when they are given proton pump inhibitors, which are the major drugs in intensive care setup and even outpatient blockade with a change in the lifestyle of the patient with acid reflux and other. And proton pump inhibitors makes them more vulnerable to develop other important drug therapies which are protective to the kidney in the form of ACE inhibitor, ARB, and SGLT2 inhibitors and other drugs. So concurrent medication also should be taken into consideration, and trying to avoid the dehydration and the major part of the sepsis in intensive care is very, very important, for which the diabetic patients are very, very vulnerable, and so that they will not get into chronic kidney disease and end-stage disease later. So AKI risk should be established or explained to the patients in every time and they will get into admission into the hospital ICU, and they should be monitored frequently. And beyond the discharge also, they should be followed up for a long time. It has been said that those patients who are discharged with AKI with type 2 diabetes should be given an ACE inhibitor ARB. And these people, after a few days of initiation of the therapy, have done much better when compared to those patients who were not given ACE inhibitor ARB with the feeling that probably they might injure more. So we request that the patient with AKI, after established with a decent creatinine, then we can start them on ARB therapy so that their kidney can be protected for a very, very long time. So the AKI looks very subtle, but the definition also says that it is supposed to improve totally. But the type 2 diabetes patients with AKI are more vulnerable to develop CKD and end-stage renal disease compared to the non-diabetic patient. That should be known to all of us. So thank you very much for the kind attention and the patient hearing. Thank you all.
Yeah. Thank you, Dr. Sree Bhushan, for the wonderful deliberation. I think what we are all scared of in a person with type 2 diabetes is a creatinine going up, whereas what we need to do is act a step in advance, picking up microalbuminuria early, doing the risk stratification, including family history, as well as avoiding any and every nephrotoxic thing that comes to a diabetic way. I would say the things that we alluded on, including prophylactic use of medications like N-acetylcysteine. We have some questions, and maybe the first one I would like to address to is to Dr. Rana. It's a common, tricky, perpetual, age-old question coming from Dr. Subhash Chatterjee, who is looking forward to know your views on how to manage a poor patient refusing insulin even on maximum doses of sulfonylurea med combination. Maybe I would refine the question that at what level of HbA1c in this patient you will insist that there has to be insulin, and what level probably you will think of doing some medical management, because now I can see prescriptions with 7 or 8 oral medications.
Absolutely. First, I'll focus on the newly diagnosed patient because that was my topic. Then I will shift to other one. So in newly diagnosed patient, when you consider insulin, it's not only HbA1c. Of course, HbA1c is one of the important parameter. Say when the HbA1c is more than maybe 10, 11, we tend to prescribe insulin to begin with. But to me, the other parameters are also very important. Number one, to assess clinically, is the patient really insulinopenic? How does it look? Like, in a first instance, when the patient comes to you with weight loss and osmotic symptoms, many a times you are not sure whether you are dealing with a patient with type 2 diabetes mellitus at all, because many times other types of diabetes also mimic type 1 diabetes and who do really need insulin. So if the patient is not a frankly type 2 diabetes, sometimes we tend to give insulin even with a relatively lower HbA1c. Second, if the patient is having a serious acute comorbidity, like say associated infection, ongoing infection like pneumonia, like UTI, then also even with a lower HbA1c, we tend to give insulin to begin with. Number three, if the patient is having severe osmotic symptom, again, we tend to prefer insulin. And once the symptoms are controlled, then we can think about other drugs as well. The important part is that the patient is refusing insulin, but if you counsel in proper way that these are the situations and this is the reason why I am giving insulin, and in many of those instances, the insulin is given for a finite period of time. If you can explain that to your patient, many patients do agree to take insulin. The second part, as Dr. Ameya has said, the patient who is already on multiple drugs, not getting controlled, now when to give A1C. Now, for each patient, you have a particular target A1C in your mind, depending on various factors we know, like age, comorbidities, life expectancy, so on and so forth. And you need to look at the two things. Number one, the difference between the current A1C and the target A1C. Now, say your target A1C is less than 7 and the patient's current A1C is more than 8.5. Now, addition of a single drug, maybe other than GLP-1 analog, other drugs are unlikely to reduce the A1C to this extent, so you need a multiple drug. And the patient who is already on multiple drug, addition of fourth, fifth, sixth drugs, those drugs won't be as effective as the use of a drug in addition to one or two drugs. So depending on these two factors, number one, the difference between your target A1C and current A1C, and number two, the number of drug the patient is already on. So depending on those two factors, you decide whether you give another drug or not. And in a patient who is not controlled with sulfonylurea and metformin, you have many options now depending on your patient profile. You have DP4 inhibitors and SGLT inhibitors, which are relatively cheap now. As you said, your patient is a poor patient. So GLP-1 analog is out of question, plus these two drugs. And other drugs like certinasin, pioglitazone is an excellent drug if it is properly AGIs. All those can be used, but again, everything depends on a particular patient context.
Yeah, thank you for a very elaborate answer, Dr. Rana. For the benefit of viewers, I would say that there has been article in diabetes therapy on how to motivate a patient to take insulin. Readers can allude to that, published in 2022 and 2020. There is one more question from Dr. Anand Deshmukh from Aurangabad, who wants to know about the concept of hyperglycemic memory. The concept that first came in UKPDS and highlighted that if you want to protect the end organs, most notably the kidney and the heart, hyperglycemic memory is very important. I would like to know the opinion from Dr. Sree, Bhushan, Raju, that how much did he emphasize whenever a person comes to him for maybe renal issue or new onset diabetes with microalbuminuria, the importance of glycemic control.
Yeah, it is very well known that the hyperglycemia is a major culprit within the kidney environment that ultimately leads to the kidney injury and disease. Very important for us to know that the initial 3 to 5 years after the onset of type 2 diabetes is very, very crucial. We always say that patients should be controlling their blood sugars. The most important discipline should be given in the initial phase itself, that they should be treated aggressively, not to get it to an extent of getting recurrent episodes of hypoglycemia, but definitely they should be treated aggressively in the initial period itself. Probably the initial discipline of diabetes control is very, very important. The metabolic memory of these patients, and it will be remembered for a long time. And I feel that any patient who comes to us with the CKD secondary to diabetes, I will tell them that the initial part of your disease, the uncontrolled diabetes, actually made a difference. We have been noting now that recently the patients who have been diabetics for the past several decades are doing very well. But the youngsters who are diabetics for the past 2 to 3 years or less than 5 years, are they coming to us with an established CKD and ESRDs? It is very, very interesting. We have been doing renal biopsies also in a good number to see that what made them very different. We have been finding out several histopathological variations and the variants in these people. But the youngsters who are unable to control their sugars properly they're taking time to understand the management of type 2 diabetes. And they're thinking that taking one simple tablet for a day and then keeping quiet is actually sufficient enough for them. But still, it is very important for them to see that they should be controlling the blood sugars in whatever the best way they can. And they should be advised to control their sugars initially so that especially the target organ injury, such as the kidney injury, will not take place. Either insulin. In fact, I advocate insulin for them rather than any other drug therapy for a short period at least. And along with the other drugs, there are so many good drugs that are available. Oral hypoglycemic agents are available. And I don't have to mention them. But type 2 diabetes patients also can be given a little short dose of, a small dose for a short period of insulin therapy in association with other drugs will be better.
I think Dr. Murthy sir will agree with me that insulin was and will continue to be the Sanjeevani booty for any beta cells under stress, may it be new onset diabetes, may it be diabetic under stress or whatever reason. I think one thing that has came out very, very importantly, and what Dr. Rana alluded to, was a need for risk stratification on day one for deciding the treatment of diabetes. And I would like to ask Dr. Subhash Chandra sir, if he's there, to let me know if a person with type 2 diabetes comes to an outpatient department, not a known case of heart disease, maybe with a normal ECG, is that enough, or that person should go some additional testing for risk stratification before treatment is decided?
So for me, any diabetic which comes with a normal ECG of course is a class 1 indication for the screening of cardiac patients with diabetes. The second important test is the urine examination for any albuminuria. And these two markers are good enough to predict that how is he going to fare in future as far as the heart is concerned. Nevertheless, conducting an echo is
paramount because that can give you a lot of clue about the HFrEF or even HFpEF. If you are carefully evaluating echo, you can look at various parameters of developing HFpEF because diabetes forms a very important comorbidity in HFpEF population. So that would be my process of doing it. Nevertheless, a CT coronary angio after a particular age gives you a lot of guidance about the calcium score and underlying coronary arteries. So the threshold for conducting CT coronary angio in diabetic population is much low compared to a non-diabetic person. I think that answers the question.
Yes, sir. Very, very well worded. The thing
Yeah,
is,
Ameya, can I ask one question to Dr. Subhash? What
yes.
is the role of strain echo? Is giving you any extra information as
Yeah.
compared to standard echo?
So stress echo is one way to go about it, but it has limitations of positive predictive value of just about 75% or so. We're still bound to miss about 25% for patients. So you would agree that in United Kingdom, the best screening tool for coronary artery disease is CT coronary angiogram. So if you have any higher suspicion of underlying CAD, you must order for a CT coronary angio, then relying on the stress test.
And any particular age cutoff where you can ask for the coronary and coronary CT,
So
coronary calcifications?
besides the symptomatology and the activity status, I think any diabetic past the age of 60 would qualify to undergo a CT coronary angiogram.
Thank you, sir.
Yeah.
Right.
Thank you, Dr. Bhadada sir, also for the to-the-point question, because CT coronary angiogram is now a test that is very discretionary. Some do it at random because just they want to do it, and some keep on deferring it till they finally land up with an invasive angio on a cardiologist's table. Dr. Rana, coming back to you, what are your tests on a first visit for a person with type 2 diabetes? Have they changed in last 5 years?
Not much really. I do test for, other than the blood glucose itself, initial HbA1c. I look for maybe a bit more of liver function test, which I used to do maybe 10 years back. Then, of course, the creatinine. The two tests I usually differ for one visit. Maybe, of course, the urine ACR, which I do not do at first visit because of the uncontrolled glycemic status. And number two, if the blood glucose is grossly deranged, I also defer lipid profile, particularly if I want to look to triglycerides. So I do it in the second visit. I tend to do an ECG as well in the first visit. And then, of course, the other tests, depending on the clinical feature. If the pointers are there, I test for that. But for routine, the blood glucose, LFT, creatinine, HbA1c, and ECG, lipid profile in many, and urine ACR once the blood glucose level is reasonably controlled.
Yeah. Thank you, Dr. Rana. There has been more and more heterogeneity in ordering, and we see people who probably prescribe medications without looking at anything, considering will the patient really have a cardiorenal problem at visit 1, and deferring, and as well as there are many people who advise CT coronary angiography, that okay, you have been found to be diabetes, so do a CT coronary angiography. Coming to a last word of conclusion from each one of you, but before that, a very quick take from Dr. Sree, Bhushan, Raju sir. CT coronary angiography involves a lot of contrast. Radiation is another aspect of it. How should clinicians be choosy about it, or it can be done liberally? Sir, you are muted.
You are muted, sir.
Yeah, diabetic patients are vulnerable for every insult, especially the coronaries, where they should be protected from that. But I advise them actually to see that they get hydrated properly before putting them into coronary angiograms. And of course, sometimes it may be difficult for them looking at their ejection fractions and all. But still, adequate hydration is very, very important. That is the only one which can really prevent in a major way, clinically and even theoretically, even literature-wise also, compared to any other drug. And other one is avoiding concurrent nephrotoxic drug therapies, especially as I stated, proton pump inhibitors certainly can make a difference. So those kind of drugs should be avoided in these patients before putting them into coronary angiograms. And as less as possible volume should be given to them. It is said that less than 120 ml can be used. Probably that is better when compared to the more volumes of contrast agents. And the type of contrast really did not make any difference over a period of time. And now the cardiologists and the interventional radiologists are very, very choosy about varieties of contrast reagents. But still, the adequate hydration and avoiding concurrent nephrotoxic agents is the most important thing in preventing contrast-induced nephropathy in the clinical practice.
Thank you to all the speakers. Just one concluding remark or one take-home message for all. Maybe I can start with Dr. Rana, followed by Dr. Sree Bhushan sir and Dr. Chandra sir.
Yes, the early detection as well as early treatment of diabetes, hyperglycemia, and these associated comorbidities goes in a long way to prevent micro and macrovascular complications. So go aggressive from the very beginning.
Dr. Sree Bhushan.
The drug injury secondary to some of these drugs are very, very important in leading to acute kidney injury in patients with the type 2 diabetes. Knowing that the type 2 diabetic patients are vulnerable to develop AKI, which can certainly take place inside without even clinical observation and in progress to CKD. So avoiding AKI in type 2 diabetes is very, very important in preventing a disease called chronic kidney disease, which is the most common cause of kidney disease in the world and in India, which is very important for all of us to know about.
Dr. Subhash Chandra, if he's here. I think sir is muted. Reaching a destination on time is wonderful, even in a virtual world. So we started on time, we finished on time. It's my pleasure to hand over the session back to Dr. Murthy, sir.
Thank you very much, Dr. Ameya, Joshi, Dr. Subhash, Chandra, Dr. Rana, Bhattacharjee, Dr. Sree, Bhushan, Raju for an outstanding session. 3 excellent talks with clear-cut messages and also a very we now go on to the second module. There is a message chapter of Endocrine Society of India and chairman of RSSDI Punjab chapter. He is a teacher of teacher and an avid researcher, founder and current secretary of social support group Aditi. He has contributed several chapters to many textbooks, including the prestigious Bible in Endocrinology, the Williams textbook of Endocrinology. He is a regular speaker for not only national, but all the important international meetings and conferences, more than 160 publications in high impact factor genre, research collaboration with major institutes, not only in the country, but abroad also. Professor Sanjay, Bhadada, the stage is yours.
Yeah. Thank you, sir, for the kind introduction. And as I understand that the first speaker is not available, is it like this?
Yes, sir.
Okay.
He has
So
some medical emergency in the hospital. Some of his
Yeah.
staff member got died.
Oh, I can understand. So obviously, like in the previous session, we had 3 speakers, the cardiologist, the endocrinologist, and the nephrologist.
Yeah.
This module 2 also had 3 speakers, but maybe Dr. Jayagopal is not available because of some reasons, so that we can move on to the second talk, and that is Dr. Bhaskar Reddy. So Dr. Bhaskar Reddy is Senior Consultant Endocrinologist and Managing Director, Vijaya Diabetes, Thyroid and Endocrine Clinic of Pondicherry. He caters more than 60,000 diabetes and endocrine patients. He is Secretary Endocrine Society of Tamil Nadu and Puducherry, President Puducherry Diabetes Research Forum. He is faculty for Public Health Foundation of India, Diabetes and GDM courses. He has more than 20 publications in various peer-reviewed endocrine journals, and he has many book chapters. and he has done several research in the diabetes mellitus, especially with the FCPD and vitamin D. He has been awarded for one of the inspiring endocrinologists of India for year 2022 by the Economic Times, and he is having capability to organize various conferences at the national and the state level. And moreover, the Vijay Bhaskar Reddy is, I know, last 20 years and very close friend, and is a great speaker. And he is going to speak about new insights into therapeutic strategy for obesity and diabetes. And we know that the obesity is the mother of all the ills, whether it is a diabetes, whether it is a hypertension. And Dr. Vijay is, I'm very eager to listen to Dr. Vijay about on this topic. So over to Dr. Vijay.
Thank you, sir. Thank you for the kind introduction. Sir was my teacher, and I thank Corona Remedies for having given the opportunity for me to participate in this Deciphering ADA 2024 meeting. I think as Dr. Amit Bhargava had told, disseminating science is the essence, and a lot of people are not able to go and listen to the American Diabetes Association deliberations. So having this type of dissemination meetings goes a long way in exposing our doctors to the current knowledge of science. So I'll just share the slides. Okay, so my topic is new insights into the therapeutic strategies for obesity and diabetes. I think part of it has been covered by the first session speaker, Dr. Rana Bhattacharjee, who had covered significantly about obesity management, the current management. I'll be talking mainly into a few newer insights, and they're in the preliminary stages, but just they'll help us in understanding how the obesity science is evolving and how the new targets for obesity management are there. So why we are giving so much importance for obesity these days? So because obesity is increasingly prevalent, and this is data from the left hand, the India map shows overall the obesity prevalence in many areas. The red color is more than 25% prevalence. This is as per the Asian Indian cutoff of BMI of 25 is considered as obesity, and BMI of 23 is considered as overweight. So as compared to Western countries and Caucasians, where they consider a BMI of more than 25 as overweight and more than 30 as obese, in the Indian scenario, we take BMI of 25 as obese and BMI of 23 as overweight. So the red color you can see on the left side, the overall India map, which is both urban and rural areas, where the BMI, we can see most of the southern regions, the BMI of more than 25 is seen more than 25% of the population. That is 1 in 4 is obese. Whereas the top graph on the right side, the red color, almost the whole of India is in red color. So urban areas, the clear prevalence of more than 25% obesity prevalence. So rural areas are also catching up slowly. The urban-rural divide in obesity is reducing, and that is why we are concerned about obesity. We know that obesity is the harbinger of diabetes and other metabolic problems. So if we cut obesity at the root stage itself, we can reduce the prevalence of diabetes, pre-diabetes, and various metabolic disorders. This is the metabolic, the ICMR NDIAB study of the prevalence cross-sectional study, which was published last year in Lancet, about the prevalence of non-communicable diseases in India. So diabetes is estimated that nearly 10 crore population has got diabetes, and nearly 236 millions, that is 23 crores, have got dysglycemia, either diabetes or pre-diabetes. It will come to around 25% prevalence. Obesity, generalized obesity, another 254 million, and abdominal obesity, 350 million. That is 25% will be obese, and if you take abdominal obesity as criteria, around 35% is obese, and that is why we need to look at how we are going to manage the obesity. The common obesity treatment, as generally followed is lifestyle changes with diet and exercise, physical activity. Often we find that patient compliance to these measures is difficult and people cannot lose more than 5% of the body weight with this. And even if they lose, we know that weight is like a yo-yo phenomenon. Whatever they lose tends to come back. So pharmacological measures for obesity, we have been using some drugs come and then they go off with due to side effects. We had fenfluramine, we had lorcaserin, we had sibutramine, we had rimonabant. So many drugs came and went off. So there was a huge vacuum in the pharmacological space. And recently this vacuum is being fulfilled as shown by the previous speakers. Dr. Rana Bhattacharjee had showed the GLP-1 receptor agonists are filling up this space fast. So bariatric surgery is effective, but it's invasive. So if possible, patient wants to avoid that, and there can be recurrence of obesity also after bariatric surgery. So this graph already the previous speaker, Dr. Rana Bhattacharjee, had showed the effect sizes of different current obesity therapies. So the left side one, the green color one, lifestyle intervention, diet and exercise, which is the foundation for any weight loss regimen. So can give up to 5% weight loss only. This is the graph shows the percentage weight loss. So Orlistat is the only licensed drug for obesity currently in India. And we can see that it's not very potent agent. It can give less than 5% weight loss along with diet and exercise, which translates to around 3 to 4 kilogram weight loss, which is not sufficient for most of our patients. Phentermine topiramate combination can give up to 10% weight loss, but that combination is not available in India. And bupropion naltrexone, again, that combination is not available in India. Both are not very potent agents. So we had liraglutide, which was licensed for use in India, but it was mainly in the diabetes usage dose where we use up to from 0.6, we escalate up to 1.8 milligram. But the weight loss dose of liraglutide is actually 3 milligram, which has not been licensed in India. So now pharmacotherapy has moved on, and all of you will be aware that internationally, semaglutide and tirzepatide have revolutionized the weight management. Even semaglutide, we use a higher dose as compared to diabetes patients. That is 2.4 milligrams subcutaneous weekly once, whereas the diabetes dose is 0.5 to 1 milligram subcutaneous weekly once. In India, again, this injectable semaglutide is not available. What we have is oral semaglutide. And then tirzepatide is revolutionized the weight management, showing the maximum weight loss in the pharmacotherapy for obesity up to 20% weight loss. Dr. Rana had showed further about the triple agonists like retatrutide, which are under the trials. And we also have the melanocortin receptor agonist, that is the MC4R, mainly for monogenic obesity. After that, if you want more than 25% weight loss, we are looking at bariatric surgery like sleeve gastrectomy and gastric bypass. So the initial part, the semaglutide, tirzepatide, and the trials have already been discussed by the previous speaker. So I'm going to go directly into the newer insights, which were discussed in the ADA 2024. So mainly, I'm going to discuss 3 new drugs which are under trials for obesity. So first agent which I would like to discuss, which was discussed and highlighted in the ADA 2024 are, one is the dual agonist T003. This is a novel GLP-1 FGF21 dual agonist showing a therapeutic potential for obesity, diabetes, and metabolic dysfunction, that is MASLD. So how does this combination of GLP-1 and FGF21 present a novel treatment strategy for metabolic diseases? So GLP-1 receptor agonist, as highlighted by the previous speaker, gives potential weight loss mainly due to the brain effects. So it has got appetite suppressing effect, improves the satiety. And in addition, it has got diabetes effect, improves the insulin secretion and decreases the glucagon secretion. Most of the weight loss due to GLP-1 receptor agonist is due to CNS effect of reduction of appetite and improvement of satiety. So we already have seen data, the GLP-1 receptor agonist like liraglutide, and then we also saw the semaglutide data, which gave up to 10 to 15% weight loss, and tirzepatide, which is a dual GLP-1 GIP agonist, which can give up to 20%, and the newer drugs like retatrutide, which are triple agonists, can give up to 25% weight loss also, but retatrutide is not yet licensed. So semaglutide and tirzepatide are licensed abroad, not in Indian setting. So how does addition of FGF21 analogs to GLP-1 receptor agonist, how does this help? So FGF21 analogs have been shown to increase the thermogenesis in the adipose tissue, improve the insulin sensitivity, improve the adiponectin secretion, and cause lipid. Also, in the liver, it reduces the lipid accumulation, improves the liver fat. So these are the mechanisms how FGF21 analog can be complementary to the GLP-1 analogs. So ZD003 is a novel long-acting GLP-1 FGF21 dual agonist. So it has got all the potential of a GLP-1 agonist like a semaglutide, not as powerful as semaglutide, but 2/3 of the effect. And in addition, it has got FGF21 potency 4 times that of the native FGF21. The pharmacokinetics, it has got similar pharmacokinetic action, long half-life similar to that of semaglutide. Thereby, it can be used as an injectable preparation of once a week. So animal models for ZT003 efficacy studies show that in diabetic obese mice, so the use of ZT003 by causing analog actions at the GLP-1 and FGF21 receptors, it can cause body weight change, improve the glycemic control and insulin sensitivity. So in DIO hamsters, that is the diet-induced obesity, hypertriglyceridemia, it's shown to improve the plasma triglyceride level. In DIO mice, the MASH mice, it's shown to improve the cause resolution of the MASH, improvement in fibrosis, liver injury markers, and body weight change. So the numbers, these are all preliminary studies. So phase 1, phase 2 studies. So ZT003, by causing analog action at the GLP-1 and the FGF21, demonstrates dose-dependent, synergistic, potent, and sustained body weight reduction, even more than tirzepatide and semaglutide, but the numbers are very small. So treatment for 4 weeks, only numbers are 6 mice which are studied. The blue color graph showing the lower part showing significant reduction, and the yellow color graph is the tirzepatide and semaglutide. So you get almost double the weight reduction in these mice with the use of ZT003 as compared to tirzepatide and semaglutide. They also showed a dose-dependent and synergistic weight reduction by increasing the dose of ZT003 and improvement in the liver parameters. That's a dose-dependent improvement in the glycemic control. The blue color graph on the left side shows the use of ZT003, which is more powerful than that of the semaglutide and the tirzepatide shown by the yellow color. So there is dose-dependent improvement in the glycemic control and enhanced insulin sensitivity in the mice models. So in summary, ZT003, which is a GLP-1 FGF21 dual agonist, it has got synergistic and complementary effects of GLP-1 and FGF21. It has shown metabolic superiority to semaglutide, tirzepatide, and Yuhan GLP-1 FGF21 metabolic disorder rodent models. Significant and better reduction on MASH resolution and fibrosis. Pharmacokinetic profile, monkey supports once weekly dosing. And manufacturing relies on the recombinant process. First in-human studies are expected next year. So it's not yet come to the stage of human studies, but animal studies show promise. So next agent, which was discussed in ADA 2024 this year, is HS235, which is a precision engineered activin and GDF ligand trap. So we know that when patients lose weight, they lose both fat mass and obese mass. So can we protect the lean mass, and can we have agents which can lean mass preserving treatment for obesity, which cause only fat mass loss? So genetic evidence links overactive activin mediated signaling with metabolic dysfunction. High activin signaling has shown to increase the adipose tissue, and it is also shown to a negative effect on the heart. HS235, which is a ligand trap for activin and GDF, that is a growth differentiation factor, has shown to improve the heart function, reduce adiposity, and improve the muscle mass. Thereby, it can preserve the muscle mass and cause only fat mass loss. In studies of mice, it's shown to decrease the fat mass by nearly 60 to 75%. And it synergizes with tirzepatide for fat-exclusive weight loss in diet-induced obesity mouse model, where the use of HS235 was much more significant when compared with tirzepatide. When combined with tirzepatide, it can give 40% more weight loss than with that of tirzepatide, which will be very phenomenal amount of fat mass loss. So HS235 is an activin and GDF ligand, which can preserve the muscle mass and lead to fat mass loss. Also, it can give protection to the heart. Finally, another agent is a combination therapy of cagrilintide, a dual amylin CGRP agonist, calcitonin receptor agonist, and tirzepatide, a dual GLP-1 GIP receptor agonist on body weight loss in obese rats. So we're combining multiple mechanisms of action, just like in diabetes, where we are not using a single drug. Similarly, here we are combining different pathways: tirzepatide, dual GLP-1 GIP receptor agonist, and cagrilintide, dual amylin CGRP agonist. So we know that amylin is a non-incretin peptide with satiating properties. Amylin is a 37 amino acid peptide produced in pancreatic beta cells. It's co-secreted with insulin. Cagrilintide is a novel, long-acting acylated amylin analog that acts as a dual agonist of amylin receptors and CGRP, that is a calcitonin G protein coupled receptor. Cagrilintide has shown to induce significant weight loss and reduces the food intake. The mechanism how amylin and cagrilintide act are mainly on the CNS. They improve the satiety, they increase the energy expenditure, they reduce the body weight. Also, they have an action on the vagal nerve and the GIT. They reduce the gastric emptying, enhance satiety. In the liver, they reduce the fat accumulation, improve the insulin sensitivity. They also have an action on the pancreas, where they decrease the glucagon secretion. Combinational therapy with incretins and the dual amylin and CGRP agonist like cagrilintide can target multiple pathways regulating the energy balance, which is a promising strategy for weight loss since it allows reduction of doses of each drug where the tolerance can be an issue. So in this study, the authors evaluated the combinatorial effect of cagrilintide and tirzepatide on weight loss in obese rats. So diet-induced obesity was induced in rats for around 8 weeks and from high-fat diet. So subcutaneous daily injection for 12 days. The rats were divided into various arms, 2 doses of tirzepatide, 2 doses of cagrilintide, and a combination of cagrilintide and tirzepatide. They were sacrificed after the period of 12 days. They found that cagrilintide dose-dependently reduced the body weight, which is the higher the dose of cagrilintide, higher the weight loss. And similarly, tirzepatide also caused higher weight loss. And when you combine a submaximal dose of cagrilintide and tirzepatide, when the tolerance will be better, the combination dose shown by the yellow color graph caused the maximum weight loss of more than that of tirzepatide or cagrilintide alone, which is expected. There is dose-dependent effect of cagrilintide and tirzepatide in reducing the cumulative food intake. And there's enhanced effects of combining cagrilintide and tirzepatide in submaximal doses in reducing the food intake. Combination of cagrilintide and tirzepatide can reduce the blood glucose more than the individual component as shown in these graphs. Triglyceride reduction shown in this red color bar is much more than the green or the blue color bar. So, which is the combination is more effective in reducing the triglyceride than that of the individual agent of cagrilintide or tirzepatide. So, also shown to reduce the steatosis, where the combination of cagrilintide and tirzepatide shown the red color bars is more effective than tirzepatide or cagrilintide alone. So, to conclude from this study in obese rats, A combination of tirzepatide and cagrilintide in submaximal doses was more effective than the use of tirzepatide or cagrilintide alone with respect to body weight change, food intake, plasma glucose reduction, and plasma triglyceride reduction, liver steatosis, and fatty liver. So combination therapy achieved greater weight loss and can be a good combination, but needs to be studied in humans. Thank you.
Yeah, thank you, Dr. Vijay, for the wonderful presentation. And since we have planned to have the question answer session at the end, so kindly stay back for the question answer session.
Okay.
And now I'll invite next speaker for this meeting, and this is Dr. Blessy Sahgal. And Dr. Sahgal is going to talk on the title, the vascular crossroads, hypertension and vascular disease in diabetic kidney disease progression. So may I invite Dr. Sahgal for her presentation. So Dr. Sahgal is consultant nephrologist and renal transplant surgeon. Renal transplant is Sree Balaji Action Medical Institute, New Delhi, India. She had more than 10 years of experience in nephrology practice. She is member of several societies like Indian Society of Nephrology, Delhi Society of Nephrology, Indian Society of Organ Transplant, Peritoneal Dialysis, Hemodialysis Society of India, and she is member of editorial board of American Journal of Internal Medicine and CRISMED Journal of Medical Research. She had done several researches and published more than 50 manuscripts. She is co-principal investigator in Protocol CYD 47 dengue vaccine trial. So with this great introduction, I'll invite Dr. Sahgal to kindly deliberate on your talk, that is vascular crosslinks, hypertension and vascular disease in DKD progression. Over to Dr. Sahgal.
Good morning, everyone. I would like to, at the onset, thank Corona Remedies for giving me this opportunity. Today, I'll be talking about hypertension and vascular disease in DKD progression, the vascular crossroad. Next slide. So, as we all know, that previously it was considered that diabetic kidney disease is has a single uniform trajectory. All the patients with diabetes and DKD will behave similarly. So, because of this, it was considered that it's a uniform single disease. The Renal Pathological Society has classified diabetic kidney disease into various type of diseases. Like it has had glomerular basement membrane thickening. Mesangial expansion is found on kidney biopsy, nodular glomerular sclerosis, typically known as KW lesions, and global glomerular sclerosis. But with recent growing consensus, it has been found that various different pathophysiological pathways are there in patients with diabetes who develop CKD. So it is not a uniform disease. It has various subgroups. And better characterization and mechanical understanding of these subgroups offers us to have a different diagnostic and have improved prognostics for these patients. Next slide. So going on to the perspective of kidney disease, historically kidney disease was classified as AKI and CKD. A new term which is known as AKD has been introduced. All these are on the basis of the time duration. So any kidney injury which is less than 7 days of duration is known as AKI. Anything between 7 days to 3 months is AKD, and beyond 3 months we call as CKD. So AKI is an acute injury to the kidney. It can lead on to a complete recovery from the disease or can cause the death of the patient. The third thing is it can go on to AKD. So any AKI going beyond 7 days is AKD. Any AKD going beyond 3 months is CKD. Next slide. So again, a summary of these kidney disease parameters. It's very important to understand this to later on understand the diabetic kidney disease. So AKI can be defined as an increase in serum creatinine by 50% within 7 days, or an absolute increase of serum creatinine by 0.3 milligram per deciliter on an oliguria of more than 6 hours, occurring for less than 7 days. That is AKI. Anything between 7 days to 3 months is CKD. AKI, which can be defined as an eGFR of less than 60 for a duration of less than 3 months, or a decrease in GFR by more than 35%, or an absolute increase in serum creatinine by 50%, occurring for less than 3 months. Anything which is with the GFR of less than 60 for more than 3 months is CKD. Next slide. So this is basically a slide which is showing the prevalence of CKD in patients who are diabetic. So if you go on to the global data, it has been approximated that half of all the patients with diabetes, they eventually develop CKD, which is normally presumed as because of the diabetic kidney disease. If you see the definition of CKD, it has two parameters, an eGFR of less than 60 or a albuminuria, presence of albuminuria. According to the global data, about 50% of patients of diabetic develop CKD. When we see the data from different countries, it has been seen that in the US, about 27% of patients are albuminuric, 9% of patients have a eGFR of less than 60, whereas 10% have features of both. Going on to the Australian data, they have more number of patients, diabetics, who develop albuminuria. Similar data is found in the demand study, which was done in the Asian population, where around 40% of the patients with diabetes eventually developed albuminuria going on to CKD, whereas only 6% of patients developed the eGFR with less of albuminuria. So patients of Asian origin, they are more albuminuric, what we can see from this study. Next slide. So why is it important to identify diabetic kidney disease or CKD in diabetes? Because it has been forecasted that the CKD and diabetic kidney disease would be a leading cause of death by 2040. When we compare the data from the cause of death or all-cause mortality in 2016, it has been seen that CKD is lower down, diabetes is lower down. Whereas the projections say that CKD, Alzheimer's and diabetes would be the leading cause of death by 2040. There has been forecasted that around 160% increase of death because of CKD would occur in 2040. So it is very important to diagnose it early, to catch them, to know the pathophysiology and to treat them. Next slide. So when we say that CKD in diabetes is not a uniform disease, so that means there are various factors which lead on to the progression of renal disease in diabetic patient. So these risk factors for the development of renal disease can be classified as modifiable or non-modifiable. Non-modifiable would be an increasing age and early age of onset of diabetes, a prolonged duration of diabetes, genetic factor. People who have history of CKD in the family, they're more prone to develop CKD themselves. Ethnicity, like we have seen from the previous slide, Asians and Australians and Blacks, they are more prone to develop early kidney disease as compared to the Caucasian population. Patients who are born as an intrauterine growth retardation, patients who were born with less birth weight, or who themselves were IUGR babies, they have less number of nephrons in the kidney, so they tend to develop CKD early. So, and the other important factor is maternal gestational diabetes. So children who are born as a birth from when their mothers develop gestational diabetes, they tend to develop renal dysfunction more as compared to people who were born with normal pregnancies. So these were the non-modifiable risk factors. The modifiable risk factors would include, again, very important, poor glycemic controls, hypertension. Now, hypertension is another important factor for development of or progression of renal disease in diabetic patient. Dyslipidemia, patients who have a poor or a lower socioeconomic strata, patients who have a sedentary lifestyle, who are obese, who are smokers, who have insulin resistance or other chronic infections. And again, the patients who have recurrent episodes of acute kidney injury, they tend to develop CKD more as compared to patients who have not had episodes of acute kidney injury. Then oral contraceptive use in females are another predisposing factors for development of renal failure, hyperuricemia and vitamin D deficiency. Out of all of these, hypertension is the most important risk factor for development of CKD in both type 1 and type 2 diabetes. Why is this important? Is because in diabetics, they lose the renal autoregulation. In normal patients, normal people, there's a renal autoregulation. So even when the BP is high, this blood pressure, systemic blood pressure is high, this blood pressure is not transmitted to the kidney. But in patients who are diabetic, they lose this renal autoregulation. So any rise in blood pressure, it's directly transmitted to the kidney and causes damage to the glomerular capillaries, leading again on to the more of fibrosis and more of progression of renal failure. Next slide. So this is a graphic representation of the glomerulus. What we can see here is if the patient has high glomerular blood glucose level, this blood glucose is filtered at the glomerulus capillaries. The glucose itself and the glycation end products, they are toxic to the endothelium, leading on to endothelial cell apoptosis. All of these causes more of inflammation, leading on to the mesangium. Mesangium is the intracellular matrix between the glomerular capillaries. So this mesangial cells, they hypertrophy, there is increase in the mesangial matrix. There is apoptosis of the podocytes, which are the cells which are present in the glomerulus. So all of these causes more of glomerulosclerosis. It causes more of injury to the glomerulus. Now, this filtered glucose is again, it passes through the renal tubules, causing to the cell, causing the problems and injury to the renal epithelial cells, causing fibrosis and apoptosis of the renal epithelial cells. All these glomerular injury and the tubular injury leads on to progression and fibrosis of the glomerulus, leading on to progression of renal failure. Next slide. So what was presented at the ADA this time was a Berry triple biopsy study in DKD and the result from the IBEAT DKD study. Next slide. This basically was a protocol research biopsy-based study, which was done to identify the phenotype of CKD in diabetic patient. So the CKD in diabetic was classified as diabetic kidney disease, non-diabetic kidney disease, and a combination of both. Next slide. What they did in this study was they collected all the demographic data. The age was collected, the diabetes duration was collected, the glucose, the blood sugar control was done in the data was collected in the form of blood glucose levels, HbA1c. Obesity was catered to by collecting data on BMI, glycated albumin was collected. Renal parameters, which were the data were collected by urea, creatinine, EGFR. They collected the data on urinary albumin by creatinine ratio. Serum protein and albumin was collected. Various parameters of blood pressure in the form of diastolic blood pressure and systolic blood pressure was collected. And the cholesterol parameters was collected. It was basically a 4-year study, and every year follow-up was done. On the basis, the patients who, out of these patients, about 96 patients underwent a kidney biopsy, and various parameter data were collected on the basis of kidney biopsy, which included histopathology, it included IF and electron microscopy. Next slide. So the results from the Berry study was they found that around 256 patients were total stratified in the Berry cohort, and they were classified on the basis of EGFR as G1 to G5, G1 being a EGFR of more than 90, G2 between GFR between 60 to 90, G3A was a GFR between 45 to 50, G3B was 30 to 45, G4 was 15 to 30, and G5 was less than 50 or end-stage renal disease. The way it was classified was on the basis of albuminuria A1, A2, and A3. A1 being normal albuminuric with albuminuria of less than 30. A2 was moderately increased albuminuria in the form of ACR between 30 to 300, and A3 was albuminuria of more than 300 because severely increased albuminuria. The patients who were included in this study were around 45% were patients who were G2, that is the stage 2 of CKD, and around another 18% were around with class 3. So around what we can say 60% or 2/3 of the patients in this were patients who were class 2 or class 3 of CKD already. Now out of these patients who were included, around 96 underwent a protocol kidney biopsy. The patients who underwent a kidney biopsy were those, especially those 80% of patients were those who already had albuminuria, either moderately increased or severely increased albuminuria. So next slide. So what we have known from the previous slide is patients who were included in the study were already those who had a class 2 or class 3 CKD on the basis of EGFR and were albuminuric. Now the subgroup analysis, the patients, according to the biopsy, they were classified as patients who had vascular reason for the renal failure. That is shown in the blue bar. The red bar includes those which have both metabolic and vascular lesions. So out of the total 96 biopsy, 35.4% were patients who had vascular lesions. These were the patients who were diabetic, had CKD, but diabetic kidney disease was not the cause of renal failure in these patients. This included a major majority, 35.4%. Around 25% were those who had both vascular as well as diabetic kidney disease as the cause of renal failure. The others included immunological, vascular, as well as mixed. If we go on to the subgroup analysis on the basis of albuminuria, about 87% of the patients who were non-albuminuric, patients who were diabetic, had CKD but non-albuminuric, 87% of those were found on the basis of biopsy were found to have non-diabetic kidney disease. So this is a major proportion. So patients who are diabetic, who have CKD, but who are not albuminuric, in those patients, a reason other than diabetic kidney disease is the cause of CKD. As the albuminuria increased, in patients who were A2, that is, had an albuminuria between 30 to 300 milligram, around 47% were vascular. Half of the patients here also were those who did not have diabetic kidney disease. Other causes or hypertension was the major cause of renal failure in this patient. A3 was definitely more of diabetic kidney disease. Next slide. A similar study was done by Mazzucco. In this study, basically 390 patients were included in this study. And it has Mazzucco study have classified diabetes, renal failure on the basis of biopsy as class 1, which is diabetic glomerular sclerosis, class 2, which is vascular in the form of ischemic glomerular or arteriosclerosis. Class 3A is those who have glomerular disease superimposed on diabetic kidney disease, and 3B were those who had other glomerular diseases. Next slide. Going on to this data from the Mazzucco classification, what they found was about 35% of patients, again, here had vascular. All of the 390, out of the 390 biopsies, 35% of them had non-diabetic disease as the cause of CKD. 33% were those who had diabetic kidney disease as well as non-diabetic kidney disease. Whereas 23%, one-fourth of the patient had other immunological diseases as the cause of renal failure, even in diabetics. Going on to the Berry classification, similar data is seen about 35% of patients with diabetes, CKD. The reason for CKD was non-diabetic. Next slide. Again, this is basically comparing Mazzucco and the Berry classification. Out of the 96 patients in the Berry group, about the DKD, that is the diabetes as the cause of kidney failure, 9% had pure metabolic or pure diabetic kidney disease, 24% had both metabolic as well as vascular. Non-diabetic kidney disease was found in 60% of patients, and the combination was found in 8% of both. So both these studies basically tell us that even in patients who are diabetic, who have kidney disease, we should not be taking it on face value as this will be diabetic kidney disease. We have to look for other factors. We have to look for other causes of renal failure in these patients. Next slide. So the second thing which was presented in ADA was Kidney Precision Medicine Project. Next slide. So this is basically a multi-year collaboration of various research institutions in which was done to study various mechanisms of AKI and CKD. Patients, the goal of these KPMP was to collaborate with various research institutions and to find out and evaluate kidney biopsies from various patients who have AKI, CKD, or other diseases. We have to define the second goal was to define the disease subgroup. Then we have to identify the various pathways and target the various newer therapies and create a kidney tissue atlas. Next slide. So the patients who were included were diabetic kidney disease, both type 1, type 2, hypertension, and patients who presented with AKI, excluding were pediatric people with less than 18 years of age, or patients who had glomerular diseases, kidney transplantation, and malignancy and pregnancy. These were the patients who were excluded from this. The patients in this project, clinical presentation of clinical data was collected. The traditional and digital pathology, including EM, was done. Various transcriptomics was run on these kidney biopsies, and we have to study this. What they studied was kidney disease progression, kidney failure, AKI, and hospitalization. The main aim was to create a reference kidney tissue cells to understand the various mechanism of the disease, to identify the targets which can be used for newer therapies. Next slide. So this is from a KPMP study. This is basically a patient with the past stain of the kidney biopsy from a diabetic patient. What we can see on the right-hand side group is this is a high power view of the glomerulus. The mesangial matrix is increased, which is in the form of deep pink color. And the arteriole, which we can see here, is also deep pink because of the arteriosclerosis. This is the mixed lesion of patient with diabetes. Next slide. So what is the impact of this? Why do we want to do a KPMP? This is because we have to identify all the patients with diabetes, all the patients with the hypertension are not diabetic kidney disease. We have to identify the various causes so that patients can be treated properly. Like if we see on the entry cohort, around 57 patients were initially labeled as diabetic kidney disease. Out of this, 42 only turned out to be diabetic kidney disease. Around 13% of patients were hypertensive kidney disease. And another 5% of patients, the cause were not identified, whereas 4% of patients actually had immunological disease of the kidney, where proper and different treatment can lead on to improvement of the disease. Next slide. So in conclusion, what I can want to say is we have to, in all the patients who are diabetic, who have CKD, we have to look out for other causes in addition to diabetic kidney disease. So a comprehensive phenotyping and biomarker discovery is important. We have to refine our disease classification so that we can treat the patients properly. A systemic biological approach to identify newer biomarkers to differentiate between diabetic kidney disease, hypertensive kidney disease, and other causes of kidney disease is required. And a precision medicine framework is needed to identify new biomarkers so that patients can be treated properly. Thank you.
So thank you, Dr. Sehgal, for the wonderful presentation and finishing very well in time. So now we can move on to the question answer session. So we got a lot of interesting questions for both the speakers. So we can go on to the first question from the chat box is that to Dr. Vijay. Dr. Tushar Mehta from Kolhapur asked, can anti-obesity drugs can induce AKI? Indeed, Dr. Sehgal also can answer, or Dr. Vijay. So we can go to Dr. Vijay. So can anti-obesity drugs induce AKI?
I think if we are using licensed drugs, there is no risk of AKI, but many people use off-the-counter anti-obesity medicines because there's a huge vacuum in pharmacotherapy for obesity. So a lot of drugs have come up, drugs and different types of treatment which may contain off-the-counter medicines. They may contain heavy metals and different types of things which are not the scientifically not proven. So off-the-counter medicines can produce AKI, but licensed medicines in India at present, we have only Orlistat, and the other agents like semaglutide and liraglutide, they're all tirzepatide, they're all well studied, they do not cause AKI. Off-the-counter medicines can cause, so we should advise our patients to avoid off-the-counter medicines, especially they may contain heavy metals. I think Madam will be able to tell better, nephrologist.
Yeah. Dr. Sehgal, please, what is your take on?
I totally agree with Dr. Bhaskar. We recently had a young lady who presented to us. She was taking some Chinese herbal medicine, which she bought online as an anti-obesity agent. And she actually developed AKI requiring hemodialysis. So definitely these medicines, the Chinese herbal medicines, have the propensity of they develop renal failure because of the presence of heavy metals. This is especially seen with the medicines which are available over the counter and should not be prescribed.
Yeah, so our both speakers are very clearly saying that use the prescribed drugs to tell our patient. And another one thing what I observed is that lot of people going to gym, and actually I've seen frequently patient landing into the acute kidney injury and requiring biopsies and all. So I think it is another platform that we should tell very clearly, because that can be another major issue of using this high dose, high protein diet, very high protein diet, and that is causing problems. So Dr. Sehgal, what do you say?
This is basically because of the steroids and some of the medicines which they take for bodybuilding. Especially we have seen with people who are going into bodybuilding competitions. So these patients, they tend to take a lot of protein powder, which is adulterated with adulterated protein powder. Per se, if you say the diet, if the patient is taking normal, homemade, proper diet, then they do not cause a renal failure. But the supplements, I don't know what is contained, what is the content of these supplements. So these patients we are definitely seeing young males and females who are deadlifters and body weight builders. They come to us with a creatinine of 1.5, 1.6. When we do biopsies for them, FSGS is the thing which we find in most of these patients. And the androgens and injections which they keep taking for the gym people they give, these are the things which we should avoid and should be counseled. It causes renal failure, and we've seen patients coming in with liver failure, fulminant hepatic failure with these kind of stuff which they take in the gym.
Yeah. So I think this is a very, very important issue and we are facing, because even in practice, various doctors are unable to guide their kids, because one of our professor from institute, they say, my son is after me to take all this, give me some articles so that I can convince him that these are not required, better you just take the homemade food and that high amount of protein is fine, but not this kind of thing. So that is one thing.
We have been counseling a lot of our colleagues, children, teenagers for
Yeah,
this. People
yes.
actually come to us with their kids and make us talk with their kids that they should not be taking all this. We've been doing it quite frequently here.
Yeah. So, Dr. Tushar, actually, in addition to this, the anti-obesity drugs can induce EKIs because the lot of drugs are causing GI intolerance, right? And if we are not having adequate hydration and not monitoring while they are on the drugs, sometimes they can cause this type of problem. So we have to be aware that if it's causing lot of GI intolerance, in that case, maybe reduce the dose or the stop for the timing. That may be another good strategy to avoid any effect of any AKI with the anti-obesity drug, right? So another question from Dr. Atul Mehta, Mumbai. Given the different pathophysiology being incriminated and manifesting different disease forms of CKD, is it possible to identify them by investigation or regular or the special? So I'll ask Dr. Sehgal, can you say, like in a teaching, like what are the clinical, what are the investigations, and maybe further deeper investigation is required, please?
Okay. So what we usually do is any patient who's diabetic, who comes to us with a raised creat, we automatically say this is diabetic kidney disease, which is not true. We have seen in various studies, we've seen in this study as well. So diabetic kidney disease or patients with diabetes who develop CKD as a result of purely diabetes is a limited number of. These are the patients we have to be on a search for other features of kidney failure. So if a patient is non-albumin, non-oliguric, but the creatinine is rapidly rising, that would per se say that it is probably not because of the diabetes. There is some other incriminating factor. So if the patient has systemic diseases, systemic symptoms, like patient has fever, patient has joint pain, patient is a young female, or patient has symptoms suggestive of a vasculitis, symptoms suggestive of lupus. These are the patients who are actually, we should be open, we should investigate them, we should do a kidney biopsy, we should do serum investigations depending upon the patient profile. So if a patient who has rapidly increasing renal failure, rapidly increasing proteinuria, patient who has taken NSAIDs, patient who has other features suggestive of vasculitis or lupus, these are the patients we should keep our eyes open. We should have a lower threshold, very low threshold for investigation, because around only half of the patients who are diabetic, they develop CKD because of diabetes. Half of the patients have developed CKD because of other diseases. If the hypertension is not controlled, the progression would be fast. So in these cases, we have to make a diagnosis of hypertensive nephrosclerosis and treat hypertension accordingly. If a patient has taken NSAID, say, patient is a diabetic, took painkillers for some reasons. These patients, they develop severe proteinuria, a rapidly increasing proteinuria, presence of hematuria, presence of systemic features, presence of rapidly worsening renal function. These are the common red flags where we should be aware, we should understand, and we should know that it's probably not because of diabetes. This is because of some other disease which is occurring in these patients. Because diabetic patients does not make them immune for other renal diseases. They can develop membranous, they can develop minimal change disease, they can develop hypertension, they can develop lupus and vasculitis, which is very common. So if we do not investigate for them, we do not do a biopsy, we do not do other blood investigation, serum investigation, we'll miss them. Another important subgroup which is we are seeing nowadays in elderly patients are patients who have MGRS. That is, patient have plasma cell dyscrasias, multiple myelomas. They come to us, diabetic patients, they will develop multiple myeloma, which is actually treatable. But we miss them because we think this is because of diabetic kidney disease. We do not give them treatment for myeloma, and they eventually land into hemodialysis and ESRD and die. So we have to be very cautious. We have to keep our eyes open. We have to look for other symptoms, other clinical features, other signs, and other investigations. So patients and proper history is very important in these patients. So we have to take a history suggestive of vasculitis. We have to take history suggestive of any malignancy, history suggestive of drug use, especially painkillers, over-the-counter painkillers. This is a very important subgroup of patients. So these we have to keep our eyes open. All the CKD in diabetes is not diabetic kidney disease.
So I
Thank
think
you.
in your slides already you've shown that is very high percentage of non-diabetic kidney disease and kidney disease, DKD plus non-diabetic kidney disease combination. So indeed it is major share rather than DKD in diabetes, right?
DKD is just 1/3 to we'll say 30 to 40% of renal failure in diabetes is DKD. The rest of them are others. So we have to be on the lookout for these others so that they can be timely treated and we can salvage the kidney and the patient.
Let me ask a very practical question.
Yes.
When we are seeing in the OPD patients of type 2 diabetes,
Mhm.
so generally one mistake I think most of the clinician do is that just look at the serum creatinine. And actually that will be a really
That's a
very bad approach. So now we are doing actually writing EGFR for each and every patient, like we are writing their BMI, their HbA1c, EGFR is a part of that, right? So how you keep a pace, because say I'm in a government hospital, do see 100 patients in a day. So how do you keep, I'll want some clue from you that how you can keep a track of EGFR that each and every time. What do you do in
See,
your
we have EGFR calculators. It has 3
Yes.
parameters. We have installed it in our hospital. We have put it in the lab itself. So lab, whenever they enter creatinine, they give us EGFR. If your lab is not giving, you can calculate it. It'll take 20 seconds, not more than that. Because I can understand you have a lot. If somebody is seeing 100 patients a day, it becomes a little hassle to calculate. But EGFR calculation will give us actually a proper idea where our patient lies, because 1.4 creatinine for a 20 years old and 1.4 creatinine for a 70 years old is not the same. The creatinine is the same, but 1.4 is not the same. EGFR would be maybe around 70, 80 for a 20 years old. It will be for 30 to 40 for a 70 years old. So, and when EGFR gives us a very important clue, because normally around 3 to 5% we say patients with diabetic, they have a 5% fall of EGFR per year once CKD sets in. But if the patient is having a EGFR fall more than that, we know that there is something else which is going on in the kidney and we need to find that out. So we calculate EGFR for all of our patients, and we have enough calculators which can be installed on the phone. Takes 20 seconds and we can do that.
Yeah. So the other
Or maybe the
question
lab
is,
can be.
is that there's MDRD and CKD EPI. Especially in patients of diabetes, which one is better?
CKD EPI would give you a better idea. CKD MBD can be used where EGFR is less than 50. Otherwise, EPI gives us a more precise this thing. Cockroach gold is totally out these days. So we've been personally using CKD EPI.
So are these data validated in Indians?
See, it's been validated in because Asian population, although less number, Indian studies not much is there. But then if Asians is there, it is validated in Asian population, which was done in the CKD EPI as well as MDRD study. MDRD did not include much of Asian population. CKD EPI study did include Asian population. So has been validated, although Indian per se, only Indian data is not there.
Yeah.
No
So
studies.
I'm taking the advantage of one speaker is missing to, I will take you to up to 12 o'clock. Yeah, Murthy sir wants to make some comments. Sir, please.
Thank you all for bringing out that very important social issue of, because we don't have an effective drug for obesity, unlicensed drugs being used. So also in the bodybuilding products, anabolic steroids and all, and you discussed about a recent issue which came up. You saw how a wrestler was made to lose up to 2.5 kilos in 12 hours. Now, is this not dangerous?
Should I? See, this is a very dangerous. Should I answer?
Yeah, please.
yeah, this is a very, very dangerous situation, because I was sitting and analyzing that wrestlers, this thing. So if somebody is losing 2.5 kgs over 8 hours period, so where is this coming from? They will not lose muscle, they will not lose fat. What they will lose will be water. So if they lose so much of water that she was probably severely dehydrated by the time her weight was done on the second day, because losing 2.1, she had actually lost around 300 to 400 of weight from the intravascular, another 1 liter from the extravascular, another liter from the intracellular compartment. Because so a person who's 50 kg, who has a plasma volume, let us say around 3 liters or 2.5 liters, out of that you're losing 500 ml. So this female had actually lost around 15 to 20% of her plasma volume. So losing 50 to 20% of plasma volume will put you into hypotension. She was not crying, she was not sweating, because she did not have water in her body to produce sweat. She did not have water in her body to produce tears. So this female, and what was happening was, because of this hypovolemia, her ADH level was very, very high. Because of this ADH level, she was actually the body was trying to conserve water. And she had finished all her water. So she was, when probably by the time her weight was done, she was risking her life because of the severe dehydration, and probably she was on shock. I don't know, because I wasn't, and no data has been said what was her blood pressure like by the time she reached the hospital. What I heard here is she was taken directly to the hospital from where she was being weighed. So probably she was severely dehydrated. She has lost around 20% of her intravascular volume. So she was actually risking her life for that weight. That is what my take on this. I was sitting and analyzing that, but it was a very risky situation. She would have, God forbid, but risked her life for that.
Yeah, Dr. Hari joined. Dr. Haris, please.
Good morning, everybody. Actually, in the same continuation, the person who won the bronze for us lost 5.6 kgs in 12 hours. Because this is a norm for wrestlers, actually. I mean, what Madam has said is I fully agree to it, but it is just for the sake of that particular weighing machine. And I mean, he was spent almost 6 to 8 hours in the sauna bath, so that whatever you sweat out, everything. I mean, each drop of H2O is just coming out as sweat, and so they are made to lose so much. 5.6 kgs actually, which is I mean, in the perspective of obesity, I'm not sure whether we can overlook, but it's going to actually create a havoc on electrolytes.
Yeah, I think that's correct, and that is very dangerous, no doubt about it. So, moving on to back to the this debate. So you mentioned, Dr. Saigal, that nephrons in Asians are less, right?
The Asians, definitely we have a different kind of, I said IUGR babies have less number of nephrons.
Okay.
Asians per se, I don't know whether there is any study which calculating the nephrons in various ethnicity, but if the patient has been born as an IUGR baby, so if IUGR baby, whenever an IUGR baby is there, there's a term known as nephron endowment. So what happens is the number of nephrons which we are born with, number of nephrons never increase in our lifetime. So every person is born with a specific number of nephrons. So IUGR baby, they are born with less number of nephrons. So what we can see it as, they have less reserve in their body. So if any kidney injury is there, a specific number of nephrons, they die, they degenerate, they fibrose. So these number of nephrons don't increase. So these patients, whenever they have an AKI, whenever they have damage to the kidney, they're more predisposed for developing CKD later on.
Right. So, going to further the next question by Dr. Jyoti Singh, Indore. Are there any parameters besides weight and BMI which can be used to monitor improvements in management of obesity? Dr. Bhaskar, please.
Yes, sir. I think now we know that especially in the Indians, we have central obesity, which is much more common than generalized obesity. So I also showed that when you look at abdominal obesity, the prevalence of obesity in Indians increases to 35%. So we have BMI may be falsely, we have this thin fat Indian hypothesis, where we have more fat in the abdomen as compared to Western countries. Indians have got more fat. That is why the BMI cutoffs are even lower than the Western criteria. So monitoring a waist circumference definitely helps in addition to the monitoring routinely weight and the body mass index. So waist circumference is doable in the clinical practice. In addition to this, monitoring the metabolic parameters, I think once in 6 months or once in a year also helps.
Yeah. And in addition to this thing, because nowadays this impedance-based methods are there, not really very costly, and these handheld kind of situations, they can, if really you want to go in further detail, weight and BMI, what Dr. Bhaskar said is that you can do the waist hip ratio, can measure the waist, and now people are even neck circumference, they're measuring the what you call arm circumference and something. There's a lot of other things are going on, but these are the standard one. But there's a lot of facilities are available. You can go do the DEXA, you can do the various other parameters, so and so. So that is there. So another question to Dr. Sehgal is that so in patients of diabetes, when you see a patient of non-diabetic kidney disease in a patient of diabetes, right? And what I see nowadays at our institutes now, nephrologists are prescribing more SGLT2 inhibitor than endocrinologist. And the cardiologists are also prescribing more SGLT2 inhibitors than endocrinologists. So I'm really curious to know that a patient who is having diabetes, but non-diabetic kidney disease, for that we are using SGLT2 inhibitors. Does it have similar type of benefit comparing DKD in diabetes and non-diabetic kidney disease in diabetes and SGLT2 inhibitor?
Yeah, definitely. As you've said that SGLT2 inhibitors, we are prescribing it to a lot of our patients, especially after this SGLT2 CKD trial. The benefit in diabetic kidney disease, as well as it has been seen very well important and cornerstone for treatment of non-diabetic kidney disease as well. It has been shown to decrease the albuminuria and decrease the CKD progression. Albuminuria definitely it comes down very, very nicely in patients in non-diabetic kidney disease. In diabetic kidney disease, what I have seen in my clinical practice is the patients who have diabetic albuminuria because of diabetic kidney disease, they also it comes down. But in non-diabetic kidney disease, the albuminuria comes down more as compared to diabetic kidney disease, especially in our subset of patients. Definitely, it has a very important role in both the diabetic kidney disease as well as non-diabetic patients with CKD, the use of SGLT2. And I think the risk of developing UTIs, we have not seen much. We have seen patients developing fungal infections, but not frank urinary tract infections, especially vaginitis and all. We have seen in patients with SGLT2, but not UTIs. So we are using it quite commonly in our patients.
Dr. Vijay, you want to say anything?
Yes, sir. I think I agree with madam. We are, I think it's useful both in diabetic kidney disease and non-diabetic kidney disease. And from our side, I think we should start using proactively in the early stages, especially in microalbuminuria stage. We don't use microalbuminuria terminology now, but early albuminic stages, I think if we use it, then we can prevent the progression right early on so that we can revert the albuminuria also. So we need to screen our patients because most of the CKD is not diagnosed early. So if we can start it at early albuminuric stage or previously the microalbuminuric stage, which can be detected only on screening, and early reduction in EGFR, we should start at that stage itself, preferably to reduce the occurrence of or progression of CKD.
Yeah. So, well, organizers can give me a hint when I supposed to stop. Otherwise, we can have a very nice discussion because it is always learning from the inter-departments. It is always pleasure to interact with the nephrologist, neurologist. So please give me a hint whenever you are okay. Otherwise, I have a few more questions to...
Please continue. We want to learn from you.
No, sir, So my question to Dr. Sehgal is that You said the Asian origin having more albuminuric. Is there any specific reason for that? Because, yeah, please.
It is basically probably because of our genetics. Again, we have more of high glycation end products. We have a system where fibrosis is more. So even in our kidneys, what happens is when you have more of sugar is filtered out of the glomerulus. It causes more of damage in our glycation end products, and our genetics is like that. We do not have very good antioxidants as compared to the Caucasian population in our population. So our fibrosis is more, our inflammation is more, our changing of the fibroblasts, apoptosis of the of the podocytes is more. So this is probably because of the genetics, where our predisposition for developing renal function, renal failure, and albuminuria is more as compared to the Western population. And again, when we see the first and the foremost thing what happens in diabetic kidney disease or is albuminuria. So EGF, because our kidney has lot of reserve, the EGFR, the increase in creatinine, the fall in EGFR occurs at a later stage. So the earlier marker definitely would be an albuminuria, would be other markers of glomerular dysfunction, other markers of tubular dysfunction. So albuminuria is an earlier marker as compared to renal dysfunction in our patient. This is probably because of the genetics and probably because the increased glycation end products which are seen in our population cannot be catered by because of our genetics. That is the reason.
Okay. So I think now I'll request both the speakers for one final comment from your side for this session or for our audience. That what do you want to say, Dr. Bhaskar? This one comment or the one take-home message from your side to our audience.
Yes, sir. So now I think obesity has become a prime focus, has become the main culprit of this diabetes and metabolic dysfunction and MASLD. So we need to work at the stage of obesity reduction to prevent the diabetes and the MASLD epidemic. Both are in huge proportions. So that is why there is a lot of focus on treatment of obesity. There is a huge vacuum in the pharmacotherapy. Now we are having good promising drugs coming up for obesity, which can even match the weight loss surgeries like sleeve gastrectomy up to 20 to 25% weight loss. And there are new insights, as I told, different FGF21 pathways and activin pathways and amylin analogs. So the future looks promising for management of obesity.
Yeah, I think here another social angle I would like to add is that kuch meetha ho jaye. This kind of ad should be stopped because I am from right now working in Chandigarh and I am from Rajasthan. There is no practice to give a packet of sweet before inviting for a marriage. But what I'm observing here is that every time the 1 kg sweet box they will bring with the marriage invitation, and they made that sweet box as a you will eat day 1, you will eat another day 2, day 3 you will give your worker at home, day 4 you will give worker your outside home. Ultimately you will try to consume that sweet, and I can understand because that is a calorie dense food and that is directly leading to the weight gain. So I think this kind of social messaging should be required for each and every level to reduce this weight, because the high amount of calorie as well as sugar is directly causing the what you call inflammatory damage to our organs. It is a pancreas, and while madam was telling that we are more using the excreting the glucose, say you are not diabetic, but non-diabetic individuals, even they are taking high amount of glucose or the sweet, maybe some peaking in the blood glucose is there that will ultimately excrete it. So that is one message all doctors can give to our colleagues and the society. Dr. Sehgal, the final comment from your side for this wonderful session.
From my side, the take-home message which I would like to emphasize is number one is we should be on the lookout for non-diabetic kidney disease in diabetic with CKD. All CKD in diabetes is not diabetic kidney disease. We have to look out for other causes of renal failure and treat accordingly. Second, we should be using which is very important, especially at the ground level, especially at the physician level, is we should be using EGFR and we should be screening patients with for albuminuria so that these patients can be picked up early and treatment can be started. It's a two very easy step. Do a serum creatinine, calculate an EGFR, do a urinary albumin creatinine ratio. Two very simple tests. Patients with renal dysfunction, patients can be picked up early, can be treated with SGLT2 inhibitors. As you've said, it's a very, very good drug, decreases proteinuria, decreases progression of renal failure. Sometimes also reverse progression of renal failure has been seen. So patients have to be picked up early because by the time patients reach us, they are already stage 4, stage 5. Earlier, patients are with endocrinologists. These are the patients who have been treated with physicians as well as general physicians, the GPs in our country. So these are the people who have to be educated that the patients with diabetes have to be screened for these two very simple tests so that we pick up renal dysfunction. Because again, this is the major cause of morbidity and mortality in our subset of patients. We do not have finances to treat, to do dialysis, to do transplant and put them into ESRD, where we can, with proper management, we can increase the time to development of ESRD by 5 years, 10 years. We have to treat them. We have to treat them with ACE inhibitors. We have to treat them with ARBs. We have to treat them with aldosterone receptor antagonists. We have to treat them with SGLT2 so that the development of CKD can be delayed. That is what my take on this.
Yeah. And of course, the elixir of life is water. So the good hydration is, I'll give another good message that we should keep drinking.
Yeah.
And
we should keep ourselves good, well hydrated.
Yeah. So my watch is telling now it is time to get up because we are sitting from last 2 hours or so. So with that, I'll hand over the mic to Murthy sir for the final comment and for the invite for the next to take over the proceedings further. So over to
Can I just make one point?
Yes, sir. Please.
Sorry to interrupt, but because there is time, I'm taking the liberty
Yes,
to
sir,
just
please.
elaborate on a point which Dr. Blessy Sehgal raised. In the use of SGLT2 inhibitors, she mentioned that we don't really get too much of UTI, but we do get fungal infection. I'm really glad that she said that, and I would like to highlight it for all the listeners, because even in today, after so many years of SGLT2, I keep encountering doctors who are afraid to write because they say UTI ho jayega. Now, I'd just like to emphasize that is not true at all. Hyperglycosuria is not a cause for urinary tract infection. And proof of that is provided by a community somewhere in Turkey, Greece, I don't know exactly. But they have a genetic issue of familial hyperglycosuria. I mean, they pass out in grams, but there is no increased incidence of UTI in that community. So mere hyperglycosuria is not a cause for UTI. I just wish to communicate that to everyone. Please use SGLT2 where required without fear of UTI.
So what we do in our clinical practice is we write while writing SGLT2 inhibitor. First, under this, take plenty of water, keep yourself hydration. That is, we write in the capital letter below the whatever water writing the take plenty of water. And if you feel any burning or a sensation, please stop the drug and report to us. So I think that can be another very simple way to educate our patient. Yeah, it is there. So that can be one thing we can always help our patient by that. So over to Murthy sir for the proceedings further.
Thank you so much, Professor Sanjay Bhadada. And just adding on, again on a lighter note, you were talking about sweets. Now, with Deepavali and all, which is to follow, you have a lot of non-sugar sweets which is advertised. Sugar-free sweets. They're all calorie dense, irrespective of what sweetness they add, and this warning has to be given. This is on a lighter note. Thank you for a wonderful session, Professor Sanjay Bhadada, Dr. Vijay Bhaskar Reddy, and Dr. Blessy Sehgal. Erudite presentation, and we got enough time for a lot of interactive discussions, lot of useful messages have been conveyed, lot of useful information, and so much to learn. Thank you so much.
Thank you, sir.
We now go on to the third module, and that will be moderated by Dr. K.V. Harikumar. Dr. KVS Hari Kumar is the dynamic secretary of our Endocrine Society of India. He is a consultant endocrinologist at Magna Center, Himayat Nagar and Fernandez Hospital, Hyderabad. Vast experience in the field of endocrinology. And I didn't know this. You have served in the Indian Army for over 24 years. Hats off. Editor-in-chief of an international medical journal and editorial board member for 6 other journals and reviewer for many endocrinology and medicine journal. Honored with more than 10 awards, prestigious awards like the Shakuntala Amir Chand and M.N. Sen Oration, J.S. Bajaj Oration, ICMR Oration, National Academy of Medical Sciences, Young Investigator Awards for RSSDI, APA, and UPDA, Best Article Awards from Indian Journal of Endocrinology and Metabolism, published 210 research papers in peer-reviewed index journals, medical journals, national and international, and authored 12 chapters in textbook of medicine and endocrine. Over to you, Dr. KVS Hari Kumar.
Thank you, sir, for the kind words. Good afternoon, everybody. It's always a pleasure to be in the forum where the learning happens from both parties. And we've been listening plenty of inputs about, say, the DKD issues. We will switch gears slightly in this module. It's I would say, more or less contemporary issues will be discussed in this module. We all are worried about why people are still dying despite so much progress in medicine, something to do with residual risk, and where do we keep the technology in place as far as practicing is concerned. Maybe we are not worse, but patients are well versed. So we have to be keeping in pace with the patients as far as the technology is concerned. And last, as what does global warming do other than reading in newspapers? Does it actually do anything to us physically as well? So without wasting much time, I first invite Dr. Aniket to speak about the mitigation and issues concerning the residual risk. Dr. Aniket is consultant cardiologist at Sree Heart Institute in Chikmagalur and has performed more than 5,000 interventional cardiology procedures, more than a decade of experience, and has been awarded as Shining Star by Deccan Herald and has got fellowships from USA also. Over to you, Dr. Aniket.
So, thank you, dear sir, for the kind introduction. So, the topic I'll be talking on today will be beyond statins, treating and evaluating residual atherosclerotic cardiovascular disease risk. It's a very huge topic, and to cover it in 15 minutes is actually a big task, but I'll try my best to cover it. So, this topic we'll be dividing into 2 parts. The first will be how do we treat the residual atherosclerotic cardiovascular disease risk? And the second part will be how do we evaluate the ASCVD risk in these patients. So in the major context will be in the diabetic patients. As we all know, the diabetic population in India, the burden that we face, and the risk of ASCVD is always high in these subset of patients. So what do we have beyond statins? So what are the newer lipid lowering therapies in diabetes that we all should know of? So first, I would like to say that the abnormal lipids increase the risk of myocardial infarction. It is a age-old data that we have, and from many studies before, and even including the InterHeart study. If there are various risk factors for acute coronary syndrome, myocardial infarction, the major risk factor is the lipids. So reducing the lipids has the greatest impact of all the comparable modifiable risk factors. So lipids play a very major role in causing the ACS, and also reduction in lipids has the benefits in reducing ACS. So the very 3 principles of LDL cholesterol lowering is the lower the better, the faster the better, and the longer the better. So when we say the lower the better, there's no particular number that we come into conclusions. It's arbitrary, but we say the lower LDL, the better the protection. The faster you do it, it's the better, and the longer duration the LDL in the lowest levels, it's better. So lower, faster, and longer of lowering the LDL cholesterol has very good prognosis in case of ASCVD risk management. So and this is also an age-old data that the statin use and new onset diabetes. So why the concern about statins started in the recent past, and whenever we explain to the patients when we start on statins, is the risk of new onset diabetes. So we all know that low to moderate risk always has incidence of diabetes, around 7% incidence is always there, and higher intensity statins. Whenever an ACS patient comes to us, we always start them with a high intensity statin therapy. For example, atorvastatin 80 milligram or 40 milligram. So the incidence of diabetes, the new onset diabetes is definitely, the incidence is always around 7% in the use of statin therapy, and with the low intensity or moderate intensity, the incidence is slightly less. With the higher intensity, the incidence is slightly more. So 62% of new onset diabetes cases were among participants who were already in top quarter of the baseline distribution of glycemia. So this means to say that though the incidence of new onset diabetes when we start statins is around a certain percentage, most of these patients who develop diabetes as a result of statin use, most of them would have been in a higher glycemic state. So that is what the sentence says. All right. So coming to the lipid management. So what are the new goals and the new tools that we have that plays a very important role? So coming to the guidelines. So coming from the bottom of the screen, I would like to say first, adults without an ASCVD. So the arbitrary number based on the data we have is an LDL cholesterol less than 100 we would like to keep, and a non-HDL cholesterol less than 130 we keep. And adults with atherosclerotic cardiovascular disease but who are not at very high risk, we like to keep it the LDL at below 70 and non-HDL below 100. And those adults with ASCVD at a very high risk, we like to keep the lowest number of LDL less than 55 and a non-HDL of less than 85. So the lower the number of LDL cholesterol, there is the better prognosis and better ASCVD risk management. So suppose in the in regular practice, what we usually see is if an adult has an without ASCVD, they do not have any risk, we like to keep the LDL less than 100 or non-HDL cholesterol less than 130. But an adults who already have a risk factors of ASCVD like a previous stroke, TIA or MI, they come under the secondary prevention. So secondary prevention, we always like to keep an LDL cholesterol less than 70. So in general, primary prevention, we like to keep the LDL cholesterol less than 100 with a non-HDL cholesterol less than 130. And secondary prevention, we like to keep the LDL less than 70 and non-HDL cholesterol less than 100. And very high risk, the lower the number, the better it is. So the same thing which has been mentioned in the slide, the primary prevention as well as secondary prevention. Primary prevention, we like to keep LDL less than 70 and secondary prevention, less than 100. And secondary prevention, we like to keep the LDL less than 70. So apart from the statins, what else do we have to reduce the LDL cholesterol levels, or what are the other non-statin therapies which helps in reducing the ASCVD risk? So apart from statins, we have ezetimibe, which has been tried, tested, and we have bempedoic acid, and newer ones, we have PCSK9 inhibitors, evolocumab, alirocumab, and inclisiran. So these are some of the newer molecules that we are having beyond statins that helps us to reduce the ASCVD risk. So coming to the data, what we have, Improve It is one of the trials which showed that addition of ezetimibe along to the statin significantly reduced the ASCVD risk. So the benefit of adding ezetimibe to statin was enhanced in patients with DM and in high-risk patients without DM. So ezetimibe adding on to the statin when the adequate control of LDL is not there. So addition of ezetimibe to statin definitely helps us in reducing the ACS events or ASCVD risk. And we all know bempedoic acid has also come into picture in nowadays, and it can be used across all glycemic spectrum. So importance is like statins, how the incidence of new onset diabetes is there, or some worsening glycemic changes might be there. The bempedoic acid from the clear outcomes data clearly shows that bempedoic acid did not worsen HbA1c, now did not increase the new onset diabetes. And coming to PCSK9 inhibitors, 4-year trial, which is already data which we already have, and evolocumab also was very safe and effective in reducing the glycemia and also in reducing the ASCVD. So coming to inclisiran, a lot of data are still pending on inclisiran. A lot of research is already going on. So it provided substantial and sustained LDL cholesterol lowering across all the glycemic strata. So a lot of data is yet to come on inclisiran. So in conclusions, patients with diabetes have a higher rates of major adverse cardiac events than persons without diabetes. So they have a higher risk of ASCVD. So definitely we have to look into this subset of patients for a very good prevention. Let it be primary prevention or secondary prevention. For LDL cholesterol, lower is better for cardiovascular outcomes, and the longer duration of therapy is better. The lower, faster, longer is the key in reducing LDL therapy. The statin-treated patients continue to have ACVD events despite LDL cholesterol reduction with statin monotherapy. And that is when the newer therapies of beyond statins has come into play. The role of bempedoic acid, ezetimibe, PCSK9 inhibitors, or inclisiran has come into play. So the non-statin therapies provide the same risk reduction per millimole per liter of LDL cholesterol reduction as statins do, and are recommended by all the societies. Recommendations have come up to use combination therapy if you're not achieving the guideline directed recommended levels of LDL cholesterol. So implementation in clinical practice lags far behind the guidelines, and evidence-based new approaches, including earlier initiation of combination therapy, were warranted to improve the implementation. So this time also they specified clearly that combination therapy would always be beneficial in reducing the LDL cholesterol level to the target levels if monotherapy is not working. So, and adherence remains one of the greatest challenges in preventive cardiology in regards to both lifestyle changes and drug therapy. Newer options are available to address this issue. So, I would like to conclude by saying monotherapy with statin therapy for reducing LDL cholesterol is good, but if you're not achieving the target levels, do not hesitate to start the combination therapy, which includes addition of ezetimibe, bempedoic acid, PCSK9 inhibitors. A lot of research is going on inclisiran too. So, now coming to the second half of my topic. What are the methodologies that we have, or what are the evaluating methods that we have to assess a patient whether he has an ACVD risk? How do we assess what is the risk factor that he comes into? So any patients with diabetes, we know they have a high risk of ACVD. So now, what are the tools that we have to assess whether what strategy that you should apply to reduce this risk? So what are the modalities that we have to identify the risks for ACVD in diabetic patients? So lipoprotein little a. So lipoprotein little a, as we all know, the higher the level, more association with higher ACVD risk. So a lot of data is available on lipoprotein little a and association with atherosclerotic cardiovascular disease. So a lot of data is also available on reducing lipoprotein little a also reduces the ACVD risk. So a lot of investigational drugs are going on now to reduce the lipoprotein A levels. So Palakad, olpasiran, and many other molecules are all still in the investigational stage. A lot of data is yet to come out, and a lot of material is still be required to completely say that to initiate the treatment for reducing the lipoprotein little a. So I would like to just say that in patients with established type 2 diabetes, elevated lipoprotein little a contributes to the increased ACVD risk clinical outcomes, as we know by a lot of data, and reducing the lipoprotein little a levels reduces the ACVD risk. A lot of investigational data trials are going on. So now coming into the other topics, what are the advanced diagnostic imaging? Is your lipid therapy good enough? So do we have any imaging methodology that we have to reduce to assess the risk assessment for ACVD? So do we have any imaging modalities that helps us to clearly evaluate the risk assessment for ACVD? So going by all the guidelines, I'm just brushing through because I would like to comment more on the other things. So overall, all the societies have recommended that there is no strong recommendation from any societal guidelines for screening using any imaging. So we do not have a typical imaging pattern to assess the ACVD risk in these diabetic subset of patients. But we have other methodologies. So what are the screening for obstructive CAD in diabetes mellitus patients? So how do we screen for an obstructive CVD in a diabetic patient? So two randomized controlled trials that we have. So one of the trials clearly shown that the study was mainly on detection of silent myocardial ischemia in asymptomatic diabetic patients. So if you subject diabetic asymptomatic patients to a CT stress testing, when we do a stress testing, if there any, do we identify the ACVD risk in them? So there was no difference in the primary endpoint of major cardiac events between the two groups. So stress testing did not have a major difference in the two groups. The other is the CT coronary angiogram. So the effect of screening for coronary artery disease using CT angiography on mortality and cardiac events in high risk patients with diabetes. So if there are patients, diabetic patients who you feel they have a high risk of ACVD and you subjected them to coronary CT angiogram, what was the imaging showed? So Again, when you divide them into two groups who underwent CT angiogram and who did not go CT angiogram, the incidence of the composite endpoint did not change between the two groups. So what did we learn from these two things? Whether how do you screen for obstructive CAD, either by stress testing or by CT angiogram? So fewer patients than expected were found to have obstructive diseases. There was no outcomes benefit from revascularization in the presence of obstructive disease which was symptomatic. So you take a diabetic patient, if he remains asymptomatic and you do stress testing or coronary artery and you found out that there was obstructive and you open the lesions, the revascularization did not prove any benefit if the patient remained asymptomatic. So significant improvements but however, whenever you do for a diabetic patient, if you do a stress testing or if you do a CT coronary angiogram and you find a lesion and you treat it adequately with the statin or a more combination therapy or with identifying the blood pressure and lowering it down. So treating it adequately definitely had significant improvements in the further events. So how do you screen for non-obstructive CAD? So we have again many tools. So the previous talk was screening for obstructive CAD that we do in the form of stress testing, in the form of treadmill test or stress thallium. The other one would be CT angiogram. So this is how do you screen in diabetic subset patients for non-obstructive coronary artery disease. So we have many approaches. We have coronary artery calcium scoring, CT angiography plaque identification, and other inflammatory markers. So identification, the presence of coronary artery calcium in the subset of patients with diabetes. So whenever you subject a diabetic patients to a CT scan to see the coronary artery calcium, based on the coronary artery calcium score, did we have any benefit in identifying these ASCVD risk patients? So higher coronary artery calcium definitely has a worse prognosis in the sense they would go on to develop further stenosis, further ASCVD events. Lower or no coronary artery calcium score had a very good prognosis. So coronary artery calcium score definitely has a role. The higher the score, the worse prognosis. Lower the score, lesser the prognosis. The better the prognosis. So coronary artery calcium score for long-term risk classification in individuals with type 2 DM and metabolic syndrome. So it's a study of coronary artery calcium done in those high-risk patients with diabetes. So that also showed that higher the score, worse the prognosis, and the lower the score, better the prognosis. So screening for non-obstructive CAD while on treatment with statins. So if a patient of a diabetes was on treatment with statins, and if you have to identify the screening, the same methodology we use, coronary artery calcium score, CT angio, plaquing, and the inflammatory markers. So basically, I would like to conclude that there are many modalities to identify obstructive as well as non-obstructive coronary artery disease. So non-invasive assessment of both subclinical atherosclerosis can help reveal the continuum of ASCVD risk. It can inform personalized strategies for CVD prevention. Current guidelines are evolving in cooperation imaging for atherosclerosis and particularly coronary artery calcium score in further risk prediction of patients with type 2 DM. Imaging can help assess the need for non-statin treatment, like use of SGLT inhibitors, GLP-1 agonists, PCSK9 inhibitors. Current guidelines do not recommend withholding statins treatment in the presence of zero coronary artery calcium score. So there is evolving data on CT coronary angiogram plaque assessment in asymptomatic patients. So basically, there are various evaluating methods to see the risk assessment for ASCVD. One is lipoprotein little a levels. Second, in imaging, no proper guidelines has come up for imaging for ASCVD assessment. But in case of coronary artery disease assessment in diabetic patients, you have to identify an obstructive pathology. You can do a stress test or CT angiogram, which is valid. And to identify in diabetes patients the non-obstructive coronary artery disease, you have coronary artery calcium score, CT angiogram plaque, and inflammatory markers. So coronary artery calcium has some role nowadays in the sense that if a diabetic patient is subjected to coronary artery calcium score, the higher the coronary artery calcium score, we tend to know that he has a worse prognosis. So we can do either subject him to coronary artery angiogram, or we can subject him to a high dose statin therapy or a combination therapy to reduce the ASCVD. And if there is no coronary artery calcium or zero score, then they have a better prognosis. Thank you.
Thank you, Dr. Aniket, for that excellent overview of covering plenty of aspects.
I'm so sorry. The time given to me was 12 to 15 minutes, so I had to rush through everything.
But we are likely to have more questions on your talk, I'm sure, because the CACs and combination therapies of statins, all those things will come. We will have the question answers at the end. And now I invite colleague endocrinologist from Hyderabad, Dr. Sree to speak about something in technology where most of the patients are using or will be using, and we also have been using. Dr. Sree is a good friend and an excellent endocrinologist from Hyderabad. Practices at Sree Diabetes, Thyroid and Endocrine Clinic. Plenty of gold medals during MBBS and MD, and best orator at TISA Meet for his presentation, and participated in plenty of conferences, India and abroad, and a regular speaker in most of our national conferences. And AR State Award in ESICON 2017 and 25 peer-reviewed publications and 15 textbook chapters. Over to Dr. Sree, please.
Thank you, Dr. Hari, for that wonderful introduction. And in the next 10 to 15 minutes, I'd like to talk about a very difficult and contentious topic for most of us doctors, which is probably going to endanger our livelihood in the near future. The role of AI in the management of diabetes. If you go back slightly in history, or if you watch the movie The Imitation Game, you probably have received an inkling that the first progenitor of AI was Alan Turing. The man who is widely credited with the modern computer, who is considered the father of modern computer science. He devised a test which is known as a Turing test. The Turing test is a test where the artificial intelligence approaches the natural intelligence, or to give it more perspective, Turing accurately put it in this manner. An artificial intelligence can be considered as equivalent to human intelligence when it can manage to trick the human into believing that it is another human. The operative emphasis is on the word trick, about which I'm going to speak towards the end of my topic. In the last 10 to 15 years, a lot of research has been, a huge amount of money has been pumped, a huge amount of effort has been done, and a lot of data and a lot of research has gone on into the use of AI in our day-to-day practice. We've got the Internet of Things, we've got machine learning, we've got deep data analysis. People have started playing games with AI. They've started predicting the cricket patterns with AI. And obviously, people have also started looking at AI as an adjunct to medical care to kind of compensate for the lack of doctors, especially in the rural setting. That was how the main initiative for the starting of AI, but now that has gone on into other areas. Radiology is one area where AI is being extensively used. And if you recall, in almost all the board games where humans have competed with machines, except in one game, humans have now lost territory to AI. AI has taken over the territory. That one game where humans have still managed to beat AI is surprisingly not chess, it is Go, which is a Chinese board game. Somewhat like Chinese checkers, but a lot more complicated. But I'm sure a decade down the line, AI is going to beat humans even there. So with this background, so how close is AI really to replacing humans? There was a recent interesting study which was done in Israel. They ranked AI with 5 specialties: psychiatry, medicine, pediatrics, gynecology, surgery. Surprisingly, AI managed to beat most of the psychiatrists at diagnosis. It had better score than the psychiatrists. It was on parity with the physicians and the surgeons. And the only place where AI had a lesser score was in the pediatrics department, as well as in the gynecology department. And as a pediatrician, before I did my DM, I do know that it is very difficult to cope with children and it requires a certain amount of empathy. In the last few years, people have started focusing more on artificial intelligence in the field of diabetes. That has already entered and is very much a part of our diabetes spectrum. If you look at the recent CGMS, the diabetes CGMS, which use this fuzzy logic kind of data. Fuzzy logic is a kind of artificial intelligence. If you look at the new 780 Medtronic pumps, where the sensor, where you have an almost artificial pancreas and a closed loop like system, where the CGMS takes the data of hypoglycemia, feeds it to the pump, uses a neural network to connect the pump with the CGMS data, and it can analyze at regular intervals. It starts analyzing where your blood glucose levels have gone down or where your blood glucose levels have gone up, checks the infusion pump, bolus and basal infusions which had been given prior to and which had resulted in perhaps this hypo and hyperglycemias. And it has the ability to correct itself over a period of time, learn from its past mistakes, so that a future incident does not happen. You get a low glucose threshold suspend. You get a slight increase in blood glucose levels at any point of time at which your blood glucose level is increasing after a meal. If you tend to have hypoglycemia after an exercise, it will suspend your insulin infusion just prior to that exercise. This is all a demonstration of what artificial intelligence has started in the management of diabetes. And that is the reason recently many of these NGOs have now come up with programs like Night Scout, Open APS, and DIY Loop. There is a major problem with the use of artificial intelligence in diabetes. It is because the data is restricted to a few corporate entities. And these entities do not generally release the data for patient consumption and population consumption. So a few NGOs have actually come up with do-it-yourself methods of getting data so that they can interpret and incorporate the CGMS data into your regular insulin pumps, not only the more expensive insulin pumps, but this data can also be jury-rigged and can be used to control the insulin therapy even in the older generation pumps. We had devices like BlueSense, we had devices like Night Scout. We also had an open APS where all the data is made widely available. And the first large-scale entity which actually came up with this kind of data was something known as a tide pool. Tide pool is now integrated with FDA. It is helping FDA in getting data, and all of this is open source software. So whatever CGMS data of any patient who is uploaded onto tide pool can be accessed by any person who is a part of tide pool. The data is anonymized, but you can get the data, you can get an understanding of how AI is interpreting the data and how AI is adjusting your blood glucose levels and your CGMS based on this data. If you have time, please go up and check out this tide pool data. And recently, this tide pool data has also started being incorporated into evaluating how diet is being influenced in people with type 1 diabetes. They have started giving people some dietary patterns. They've started looking at pattern recognition. Which diet, because all of us know uniformly in diabetes that not every patient reacts in the same way to similar diets. Some people do very well on millet, some people do very well on wheat. Some people have slight blood glucose rises with sugar, whereas some people have major glycemic excursions with sugar. Some fruit cause blood glucose excursions in a few people. Some people are allergic to a few food substances. So if you have a food diary and you inject it into the tide pool and you upload all this data into the tide pool, this tide pool can interpret your data and can actually tell you which food is causing which particular glycemic pattern so that you can adjust your dietemic pattern based on that. This is one of the biggest advances which has been made as far as the use of artificial intelligence in diabetes is concerned. Second thing, sequential data processing, something known as a recurrent neural network, is now increasingly being utilized in the management of diabetes, both type 1 diabetes and type 2 diabetes. Most of the time, whenever you look at data processing, and this is something which is a bit difficult to understand, this is almost something which is known as a first pass data interpretation. You inject all the data into the system analyzes the data and gives you an outcome. But nowadays, most of this artificial intelligence have started looking at mechanisms known as RNNs, recurrent neural networks, where you upload the data into the system analyzes the data, gives you some outcomes, but again, after a day or two, it reverts back, loops back into the system. Once you feed it new data, maybe your dietary data or your CGMS data, it re-explores this data and it gives you newer findings. The more data you feed into the system, the stronger the system becomes at analyzing a particular pattern or a dietary pattern or an insulin injection pattern for the patient. And it helps us in giving better and better data so that the patient starts having lesser and lesser hypoglycemia and hyperglycemia, and the amount of time which is spent in range increases. This brings us to another point, which is known as pattern recognition and classification. The basic backbone of any artificial intelligence network is a pattern recognition. you have to understand that this was what was initially termed by Alan Turing as an imitation game. The artificial intelligence, even the extremely good artificial intelligence which we have at this point of time, does not think. It only imitates. Its main advantage is that it can process huge amounts of data in a very short period of time. It imitates the thinking pattern of the person who has programmed the artificial intelligence and who is feeding the data into the artificial intelligence. It takes in a large amount of data. It imitates your thought patterns, your action patterns, and gives you an outcome which is similar or even sometimes even superior to what could have been given by human brain, which is working in this pattern. And that is where this pattern recognition and classification comes in. This is extremely useful for a majority of us in classic situations like somebody is having an exercise. Repeated exercise gives you repeated hypoglycemias. Recognition of this pattern in somebody who's not only on an insulin pump, but somebody who's taking subcutaneous insulin can help this artificial intelligence warn the person about hypoglycemia. It can either ask him to take some oral intake. It can ask him to reduce the dose of insulin, or it can ask him to cut down his exercise so that he doesn't experience hypoglycemia. Pump use with this is already very well known, and I'm not going to speak further about it. An interesting take on this virtual artificial neural network and pattern recognition was recently published in the ADA 2024 guidelines, where we had what was known as a virtual DCCT project. What they actually did was they went back to the old DCCT data of 1993, picked up the 7 times blood glucose profile of these patients, and gave us a graphic representation of their HbA1c, which had fallen based on the SMPG data. They gave us a reproduction of the amount of HbA1c pattern which had fallen over the period of 1 year in the DCCT, which when compared to the actual DCCT data was almost identical to what was seen with the artificial intelligence network. And more importantly, it actually did a retrogressive time in range calculation for these people. If you recall, we did not have the CGMS devices during 93 to 97 period, which was the time of DCCT. It actually also calculated a putative time in range for all these patients who were part of the DCCT. And it concluded that people who were on intensive insulin therapy as opposed to people who were on conventional insulin therapy actually spent 70% of their time in the time in range, which was what actually translated to lesser incidence of micro and macrovascular complications in people with diabetes. And that is how powerful artificial intelligence can be in the management of diabetes. The most important utility, this brings us to the question. So these are all the various potentials of artificial intelligence. So as a clinician, how can I use it in my clinical practice? We have 2 main questions. One, can we use AI to harness our day-to-day clinical practice? 2, is AI going to replace me as a doctor? And I'll answer both these questions. The first question, how is AI going to help you? In the short term, you have to understand that AI is still in its infancy. 10 years down the line, AI is going to be much, much more powerful because AI sophistication increases in a geometric progression. AI can be a multidisciplinary team. If you're running a diabetes clinic, AI can help you take appointments. It can help you give diet counseling to your patients. It can help you demonstrate insulin injection patterns to your patients. It can help you educate your patients. Most important for all of us, it can help you answer all those pesky questions which are answered by your patients. So every time somebody comes up with a YouTube query or somebody comes up with a Facebook or an Instagram query, rather than us fielding it, we can always give it back to the AI so that AI can handle it in a better manner, get access to data and respond to the veracity of whatever claims are laid by the patients. AI can help in the patient maintaining food diary. Most of the patients, once they leave our clinic, we do not have any control over our patients. AI can help us in helping them understand how to maintain a food diary. The most important thing, calorie counting. Now there are a lot of artificial intelligence apps which can look at a patient's plate, calculate not only the calories, but also the various food proximate principles, carbohydrates, proteins, and fats, and tell the patient what is ideal for the patient depending on his oral medication load or the insulin load, and also give a feedback to the doctor in real time as well as when the patient comes back to us for a visit. And of course, carb counting and insulin dose calculation and insulin correction factors, they're already being used by majority of our insulin pumps, and These have already come into regular day-to-day practice. Automated replies to a lot of questions which are asked by your patients can also be given by AI, because this takes up, especially now that post-lockdown, we've used a lot of WhatsApp. This has taken up a lot of our time. This is where AI can come in. Interpretation of self-monitored blood glucose charts. Many of times our patients can actually come in with the self-monitored blood glucose charts. Reading all those data of months together is very difficult for us. We just put it into the AI. The AI can analyze the data. It can tell us about the patterns of the blood glucose charts. More important, it can also tell you whether the patient is being truthful with doing the readings or the patient is just writing the readings. AI is very good at picking up liars, most probably because AI itself is a liar, and I'll explain why later. And later on, I'm sure the day is not very far off when AI will also act as a lie detector. Many times when the patients are sitting across us in the OP, we ask them, are you taking your medicines properly? Almost all patients will answer yes. But when we look at their data, there is no correlation between their blood glucose values, their HbA1c values, their medication, and the actual clinical picture. If AI is integrated, people are wearing a smartwatch, and that smartwatch data is integrated with your AI data. You can actually make out whether the patient is lying or even telling you the truth. This might not be legal, but this is very much possible. The other area where AI is helpful is in predicting which patient is going to go in for which risk in diabetes, because our main role as an endocrinologist is not in treating the blood glucose values, it is in preventing complications. Endocrinology is essentially a preventive specialty, predicting risks, predicting family history, and also in deciding which type of diabetes a patient has. Is it a monogenic diabetes? Is it a FCPD? Is it a type 1 diabetes or a type 2 diabetes? It also helps you monitor patient behavior outside the clinical setting, helps you interpret large amount of real world evidence, and also even the insurance databases. These are all the things which AI can do. It can also calculate your basal insulin doses. It can adjust your oral tablets. It can adjust your medications. It can do anything it wants to do. And it is only going to get better and better. This brings us to the next question. Will AI replace us? Can AI replace us? Unfortunately, the answer is yes. To a majority of doctors, it's already replaced a lot of radiologists in clinical practice. It is performing better than a lot of radiologists. But some areas, like I said, where AI cannot actually keep up with the doctors is empathy. This is very commonly told. AI does not have empathy at this point of time. Or at least AI cannot pretend to have empathy at this point of time. But AI can, it is very possible. If you look at Turing's original data, it is very possible that at some point of time, AI can at least imitate a person having empathy. And if somebody is dealing with an AI system in a remote setting, rather than having a face-to-face consultation with a doctor, having a remote telephonic conversation with a doctor, it is very much possible that AI can entirely replace an endocrinologist, a physician, or a diabetologist. This brings us to the biggest question. Can I trust an AI? The answer to this is no. Recent data, in fact, a couple of months ago, there was a project from Meta called as Cicero, which was being used by Meta to develop a board game called Diplomacy, to play a board game called Diplomacy. While they were going through their game, they actually discovered to their surprise that the AI can lie, AI can cheat, AI can manipulate data. AI can do anything to its advantage because AI has only one program. AI is essentially programmed to win the game. Once you start incorporating AI into the program, you give it a pattern and you tell it to win the game. It will do anything possible to win the game. AI can fake safety tests. A majority of times when people actually go ahead with AI, you have something known as a safety test. You test the AI to see whether it is safe and it can be used, whether it is replicating too rapidly so that it is not safe for general consumption. It can write its own programs. When people started doing the safety tests, they discovered that during the safety test, AI pretended to be dumb. And after that safety test had been concluded, AI started replicating the program itself at a much more rapid rate. So AI has a flawed moral compass. Like a few of our doctor colleagues, AI also is morally flawed. So unfortunately, brings us to the question, is AI useful in diabetes? It is very much useful. Can I use AI in my clinical practice? Yes. but someday it is going to call up your patients and start diverting its patients to you. Can I help AI? Can AI replace me? The answer is yes. AI is probably going to replace you a couple of decades down the line. And especially if you are working in a corporate setting and not working for yourself, many doctors might be made redundant. The fourth question, which a lot of our patients should understand is, can I trust AI? You definitely cannot trust an AI. If AI in its infancy can be so manipulative, imagine how bad AI is going to be 20 years down the line. And because AI doesn't have a moral compass, and you can't punish an AI if a patient has death, you cannot file a case against AI. Think twice before you start using an AI as a substitute for a doctor. This is a very complicated subject. With this, we can go on for hours and hours together debating about the ethical problems, the practical problems, the advantages and the disadvantages of AI. This requires a lot of understanding of your basic computational knowledge. But I've tried to give a brief gist of the AI. It is too vast to be discussed in 15 to 20 minutes. And if there are any questions, I'd like to take them at the end of this meeting.
Thank you, Dr. Nagesh, for highlighting the good, bad, and ugly aspects of AI. I'm sure we are looking at only the good as of now, but the bad and ugly will follow as what he has said. But nevertheless, we need to keep ourselves updated as per the changing times. We will take the question answers at the end. We'll move to the last one, which is concerning we discussed partially in the discussion of the previous session about how people are losing 4 kgs, 5 kgs in few minutes or few hours, and what does it do to the body? And in the same perspective, what is the changes of the global warming? We all are in that comfort zones and not wishing to get away from that comfort zone. And does it do any good or bad to our system and especially to our kidney function? We have Dr. Siddharth, who is going to educate us about some of the recent aspects in this. Dr. Siddharth Lakhani, please. Can we have his CV here? Nephrologist who is going to deal with us. He's from consultant nephrologist at Fortis Raja and Gislok Hospitals, Mumbai, and director at Lakhani Kidney Care, member of many associations and published many articles in the and participated in many trials. So to Dr. Lakhani, please.
Hi everyone. So hi. So good afternoon to all. Thank you for probably helping out with the technical hitch here. So I'll be discussing on something new, something innovative. We always keep on discussing on something of diabetic kidney disease, probably updates on transplant, updates on incompatible donors or probably incompatible transplants. Here we are today probably to discuss on heat waves and kidney. So we have been probably listening to a lot of CKDs and CKD of unknown etiology. And with time, we have a lot of literature now to support heat wave as a cause of CKD of unknown etiology. Not only heat probably as a cause of CKD of unknown etiology or CKD of U, but it also probably fastens or probably leads us sometimes to progressive diabetic kidney disease and new onset diabetes. So I'll be going through some slides probably to just prove what I'm trying to discuss next. Yeah, so all of us know, so unless proven otherwise in a patient with long-standing diabetes, most of the times a kidney disease or probably an increasing creatinine with or without proteinuria is mostly a diabetic nephropathy. With time, diabetic kidney disease has the reason for CKD. Now we have something called a CKD of unknown etiology. So it's probably more towards workers who work in agriculture or probably sugarcane fields. And this is where the factor of heat stress came into probably as a role of causing this CKD of unknown etiology. Next. So as I said, probably the literature also says that probably in the United States, diabetic kidney disease remains as a major cause of concern and major cause towards probably the reason for CKD. And as per the USRDS data 2022, the reason the CKD of diabetic etiology has increased from 2016 to 2020. Next. Yes. So in any patient, probably the kidney disease, whether it is diabetic or non-diabetic, you can have it defined by two ways. One is a drop in GFR, which is usually less than 60 ml per minute per 1.73 meter square, or probably a presence of proteinuria. In type 1 diabetic, the rate of probably prevalence is somewhere around 50%, and when you see type 2 diabetes, 50 to 60%. Next, of CKD in different population, and the percentages are probably somewhere around same. Now coming towards the topic today, which is heat stress, as I discussed. So heat stress, basically, whenever there is an exposure, it gives us to two kinds of stress in a patient. One is passive, where a patient gets a heat and there is no probably physical exertion which the patient has. Second, there is an active heat stress where patient already is getting a heat stroke as well as patient is exercising or working. So of course, when the patient is working or exercising, there is an increased metabolism and there is a heat generation inside as well. So there's a heat from outside as well as heat from inside. Now, whenever we see a thermoregulation or a body, the balance is between heat gain and heat loss. So when we start losing heat, that is by vasodilation, so we'll lead probably to development of stress and evaporation of water through the body, which will probably try to negotiate the excessive heat which is gained. And the core body temperature probably will increase only when your heat gain, what you're receiving via, will be more than the heat loss. And that is where the imbalance, or that is where the disease triggers and the disease starts. Next. Yeah. So when we discuss on heat stress, do we have any mechanism by which we can measure heat? Yes, do we have? So, but it's not usually available in any, whatever studies are there, the core body temperature was not always studied. What is studied more commonly is the ambient temperature by using a bulb globe thermometer, which is commonly there. What morely correlates is the amount or the peak heat which is received by the patient and the percentage of hours in a day, or probably percentage of days in a week, whereby the patient has received the amount of heat stress which is much beyond the peak. So that is where what is important. So how much you are receiving, and in a day or in a week, probably what is over and above the peak. So that probably leads towards more of dehydration, and that is where we probably start developing the changes due to heat stress. Next. Yeah, so probably this was way in 2018 when first published in Lancet by Flores et al. They have researched over 110 studies with probably more than 500 million workers from 40 different occupations. And the study was probably, which quoted that 15% of patients having some or the other heat stress. And of this, 15% workers with kidney complications had heat exposure. 15 million workers in USA had some heat exposures. And overall, 230 million workers in Central America, India, and Sri Lanka had some or the other occupational heat exposure. So the data very clearly said that probably the kidney disease patients here had some or the other exposures to heat, and the numbers were clear. Next. So now, how do we basically say that really this disease, what is happening is heat induced or no? So probably in NEGM in 2019. So the heat stress study which was studied, and they had quoted that this is more common in geographical regions where patients had probably from the lower and middle economic nations. So that was first thing. And of course, the disease or the heat related findings were more common where there was poor health infrastructure and diminished access to probably to cope up the heat mechanism. So of course, we see this heat exposures to all of us. But this is more, the disease is more common when the coping mechanisms like getting available clean drinking water are probably interim period where the heat exposure can be reduced. So this is not there, and that is probably leading to develop heat disease in workers more. Next. Now, what normally, if we are exposed to heat, how can we develop, or what are the effects on the kidney? I'll probably in next 2 or 3 slides, I'll be expressing that. So in Nature, published in 1958, it was clearly studied that any temperature of 0.5 to 2 degrees Celsius increase in the core body temperature will reduce your organ flow, blood flow by 15 to 30%. And The GFR change will be significant with this increase because there will be difference in the fluid intake, and of course the renal result will start going down. So these are two important factors. With this, they also studied that with heat stress, your urinary sodium starts falling down, so which they could easily study in first 2 to 3 hours only, and the urine volume, which goes down to as low as 20 ml per hour. So these were the findings which were studied right in 1958. Next. So these are physiological effects which were known to us already. In EJAP in 1979, again, they studied multiple young people where they could find even a significant increase in plasma renin activity, which was seen when they were exposed to around 90 minutes of 46 degrees Celsius. So this was physiological effects on kidney, which they studied in 58 and then probably in 79 as well. Next. One more study where probably in 1958, this was a heat exposure to around 41 degrees. And as I already discussed, they could significantly see a decrease in urine flow, a decrease in urinary sodium. Though there was no direct measurement of ADH here, but yes, ADH levels started increasing in this patient. So these three were the common mechanisms which they could probably correlate. Now, do we see something of diabetes and kidney disease and how probably heat can contribute here? What we are seeing is probably once there is a heat exposure to a patient, as I already discussed, so there'll be a diminished access to water. So this will lead to probably a dehydration, which is there. Dehydration will increase vasopressin in the body, and vasopressin increase itself will lead to diabetes mellitus. So this is where probably a factor is seen. And this is proven probably by seeing plasma tonic or plasma tonicity levels. So when contributed plasma tonicity independently had a 2 times higher risk of developing diabetes in a patient than probably whose tonicity was normal. Next. Now, vasopressin, yes, multiple studies probably published in 2010 showed that increase in vasopressin, one of the mechanisms I said, heat, multiple other mechanisms which could probably increase your baseline vasopressins. They were independent predictors of probably new onset of diabetes. So they could be related to heat or they could not be. Next. Now, going through probably fewer things, as I already discussed, heat stress, what are the effects seen probably on a diabetic patient? Hypertonicity, first important mechanism, and second is vasopressin. So these are predictors which will probably, if patient doesn't have diabetes or patient is pre-diabetic, will predispose them to develop diabetes. Second is, as I already discussed, so it is the extreme heat exposure which this patient develops, which probably makes them more prone to develop diabetes. In a kidney disease, as I already discussed, CKD of unknown etiology, most of the studies which were done, the diabetes was excluded in these patients, and heat stress was one-to-one directly correlated as a risk factor to develop CKD. Next. Now, any patient probably who's developed an increase in creatinine with heat exposure, three important mechanisms, what we discussed. One is dehydration and desalination, which I probably said. And this could be hemoconcentration, which could be reversible if the worker probably starts getting adequate amount of water and an interim period where the heat exposure could be reduced. Second important mechanism is hemodynamics, which probably shows a reduced blood flow, and that is how there is a change in GFR. This as well could be reversible sometimes. And progressive CKD, probably if the altered hemodynamics and probably the altered hemoconcentration doesn't change, it can go to development of progressive CKD. Other mechanisms which could probably heat related could be inflammation, oxidative stress, which this could cause, and probably a dehydration, which could lead to hyperuricemia, and that inadvertently could lead to probably development of CKD. Next. Yeah. So again, study in 2019, probably, which was heat stress on kidney. This was studied in 105 sugarcane cutter workers, somewhere around 30 years. Their blood and the urines were measured before and after they went to their shifts. And none of these patients had diabetes. Next. What they could find in their studies is three things. Whenever there was heat in this patient, the GFR dropped by as significant as 21%, which is a significant thing. And what they could correlate is significant amount of hyperuricemia seen in this patient. Now, we also have some animal studies probably of the mice, which again had where the mice was exposed to heat. One mice had an enzyme called as fructokinase, the other did not. Next. So when this mice probably was exposed to long-term heat over a period of day and night, they used to receive some water. Whichever mice probably had an enzyme fructokinase in them, they were more progressive to develop chronic interstitial fibrosis and increase in collagen. So a mice with fructokinase, which probably is a mechanism to increase hyperuricemia in this mice. So heat-related stress with an enzyme probably which causes hyperuricemia led to more of IFTA than probably the ones who were lacking the fructokinase. Next. Vasopressin and kidney, I had already probably mentioned. Yes, so all studies have shown a decrease in GFR with heat, and probably any reason of increase in vasopressin could be heat or could be something else, could have a significant drop in GFR. And these effects were also seen of vasopressin and kidney disease. This was irrespective of the albuminuria in multiple studies. Next. Yeah, so again to prove in 2003, when there was vasopressin related changes, when vasopressin 2 antagonists were used, the albuminuria and probably a drop in GFR was lesser in these patients. Next. Yeah, so this is important probably to summarize all the mechanisms of heat probably which could lead to even diabetic kidney disease. As we already said, if the exposure occurs and there is no exposure to water, this can lead to dehydration, desalination, and an increase in core body temperature. Dehydration could probably lead to hyperuricemia, and if this patient has some or the other exposure of NSAIDs, this could again lead to probably developing them to more towards chronicity. Dehydration will lead to one of the mechanisms lead to increase in vasopressin or an ischemia which could occur. Dehydration again will promote more of crystalline formations in the tubules, which will again develop them to develop interstitial injury. Few cases of increase in body temperature will lead to increased inflammation and rhabdomyolysis. This all probably could prolong towards a nephropathy, or in a diabetic patient, diabetic nephropathy as well. Next. Yeah. So again, multiple heat stress and CKD, not directly studied, but in the DAPA CKD, they could study and the outcomes were very clear. So total DAPA CKD published in NEGM in 2020 included total of 4,304 patients. Almost 3,000 patients with diabetes were randomized to DAPA versus placebo, and a mean follow-up was around 2.4 years. Next. In that study, it was very clear that DAPA had shown a significant reduced risk of developing CKD. Now, this is probably a graph or a map graph which shows the amount of heat stress which was there and a significant change in GFR which we could see, they could see in this. So, of course, each individual had a different heat exposure at different times, but it corresponds approximately that in a hot, humid climate, the GFR would probably decrease by around 3.7 ml per year. So that's a significant drop in a GFR when there was heat exposure in the DAPA CKD trial. Next. Yeah, so again, probably in patients with or without diabetes, heat could probably lead them to more of CKD. Of course, if they have diabetes, the progression of diabetic kidney disease also was much faster. Next. So to conclude, take-home message, heat stress is increasing and disproportionately affecting most vulnerable ones, the ones who are not having adequate exposures to water and probably good shelter. Stress map to know what are the injury pathways with diabetes and of course chronic kidney disease and heat stress induced chronic kidney disease. The effect of heat on kidney disease are apparent at individual and population levels, and this may vary depending on the heat exposures the individual or the population has. And directions probably to improve the hydration as an early part of slowing down CKD. And of course, this all effects were vasopressin induced. So hydration would remain as a major factor probably to slow down or change down in the progression of CKD. Thank you so much.
Thank you, Dr. Siddharth, for that nice overview of explaining about hydration, especially, which is most important as far as the...
Hari Kumarji, you are mute.
No, can you hear me?
Yes, we can hear you, sir.
Oh, so Dr. Siddharth, thank you for explaining about the importance of hydration, especially in the setting of kidney and global warming. We have few questions. We will start with Dr. Aniket first. Dr. Darshan asked Dr. Aniket, is there any benefit of ezetimibe beyond gut pleiotropic benefits?
So can you hear me?
Yeah, please go ahead.
Yeah, so ezetimibe as such, in our day-to-day clinical practice, we usually use it as an add-on therapy for statins. So if the starting with statins, we do start, and if the target levels of LDL cholesterol is not achieved, then only we add on ezetimibe to bring down the LDL cholesterol to target level. So it's an add-on therapy to statins. So apart from that, as far as I know, pleiotropic effects are 2-3 we are known, but not clearly documented, no clear data to say typical pleiotropic effects apart from the gut.
Oh, thank you. And in continuation of that only, is adding ezetimibe to statin exhibits supra-additive effect? That has already been answered. It is obviously
Definitely, there is no question about that because in the Improve It trial, it has been shown more better prognostic events, less ASCVD events. So definitely, add-on therapy of ezetimibe to statins to get the LDL to target levels has a significant benefit.
Oh, Dr. Nagesh, Dr. Atul asked from Rajkot how to use AI as an enabler in diabetes management. He wants AI to help him in managing.
That I've already answered. It can do everything in your management. It can even replace you. It can take your appointments. It can educate your patient. It can keep, once the patient has left your clinic, it can stay in touch with them. And a lot of times we start patients on basal insulins. And then we keep telling them, check your blood glucose levels every 3 to 4 days, get back to us. We'll keep increasing your basal insulin levels, or we give them a protocol for increasing the basal insulin levels. This can be done by your AI. It can also help them with diet counseling. Sometimes, a lot of times, patients get back to us asking us, can we eat this? Can we eat this? How to count calories? That can also help you as an enabler in calorie counting, not only in diabetes. This can also be used to a significant extent in other disorders like PCOS. It can be used in thyroid. It can be used in a majority of disorders as an enabler, or even a replacement for some of your staff, especially if they're not working, because manpower shortage and manpower difficulties are a major problem in a clinical practice. In all these areas, it can also help you in publishing papers. I think one of our colleagues, Om Lakhani, is an expert at this. Nowadays, except breathing, everything else is done through AI. He's an expert at that. He puts in his articles, raw data, through an app called Claude, and that writes out most of his articles for him. It can help you in writing articles. It can help you in writing patient education information sheets. It can also help you in your research, collating data, doing Excel sheets, analyzing Excel sheets. But you will have to learn to give it the proper prompt, because essentially AI is all about how you ask a question, how you prompt it. And as time goes on, you also need to pick up when the AI is live. This we have experienced because I do quiz on a major league. A lot of times when we go back to AI and ask them obscure quiz questions, the AI starts lying. This I've personally experienced. And when you catch it at that, I am sorry, the AI is the standard response of Chat GPT and the Google AI is, I am sorry, I was not aware of this limitation. I will now use it to correct myself. This I've personally experienced for a lot of my obscure quiz questions. This is something which you need to know when you use it as an enabler.
We will shift gears from an Endo Lakhani to a Nephro Lakhani. Dr. Lakhani, should we start advising diabetic patient to be careful about heat exposure? What would you advise a patient?
Yes, definitely. So, lot of, as the question always comes in, that probably so many has diabetes, why some progresses faster than the other. In that risk factor list, most of the times what we consider is probably uncontrolled sugars, uncontrolled blood pressure, cholesterols, and proteinuria. Now, probably as a part of heat, which definitely exposures will vary country to country, but that probably will have to be advised, and probably slowly that will start coming into our routine day-to-day practices also.
Okay. Thank you. Dr. Aniket, apart from diagnostic methods, what you mentioned about CAC, CTA, all other things, another doctor wants to know why not do thallium stress test, which will save the patient and his pocket from unnecessary angiography and angioplasty. What is your comment on it?
Yeah. So now, for a thallium stress test is a good test. It is one of the stressing methods to identify an obstructive CAD. So whenever we talk about thallium stress test, there are two important things we have to consider. One, it is a little bit of an invasive procedure in the sense you have to do either in the form of exercise, the treadmill, or otherwise a dobutamine stress, and then inject the thallium. So subjecting a person who is asymptomatic just because he's diabetic to a stress test itself is questionable. So the least minimum thing that you can do is a regular treadmill test. So that is the least invasive. If he can walk, you can get a lot of information. But when you subject him to a thallium stress test, it is a little more invasive. One. Second thing is, when you compare it to angiogram, definitely it is more benefiting to the patient because it is less invasive compared to an angiogram. So when do we do thallium stress test? Whenever you do a normal regular treadmill and you have some changes over there, and to suspect anything, you can do a thallium stress test rather than a angiogram. So thallium stress test is definitely, you can do it, but only if an indication is there. It cannot be used as a routine screening methodology for all ASCVD risk assessment. So better risk assessment tool is a treadmill test, and a treadmill test shows some changes. Then you decide whether you want to go for an angiogram or you want to go for a thallium stress test. That makes more sense rather than subjecting everybody to a thallium stress test, which is not easily, available also. It has to have a nuclear center, and at the same time, it is not advocated as per the guidelines also. So any changes in the treadmill test, then you take a call whether you want to do a thallium stress test or you want to do a angiogram. That decision based on the risk factor assessment, we can take the decision. So treadmill is less invasive than thallium stress test, and whereas angiogram is more invasive than a thallium stress test. So in the present scenario, what we want is to, for risk assessment in an asymptomatic individual, is make him less invasive as possible. So the only two modalities that you have is one, treadmill test or a CT calcium scoring, the least invasive methodologies. So any changes you find in these two, then you can always go for either a CT angiogram or a CT coronary either a conventional angiogram or a thallium stress test. So the basic still remains as treadmill test or a coronary calcium score. Any changes in this, then you go on either CT angiogram or a conventional angiogram or a thallium stress test. Yeah. Directly jumping into thallium stress test definitely is a definite no.
Yeah, the basic idea of behind a test is you should be clear as to what you're looking for in that. So not the availability or not the cost what matters. It is actually what information you are looking from that investigation what matters to choose a particular modality. Absolutely fine. Dr. Siddharth, apart from kidney, which organs are more vulnerable because of the warming?
I think as we start seeing probably changes in kidney, changes in probably cardiac as well as in the neurology status will have to be studied in detail, and probably that is where it is going to be. And obesity. So that is one more thing probably which will lead as a part of center to everything. So endothelial dysfunction leading to multiple organ injuries.
Okay. Murthy sir is here. Sir, how do you, this is a question to all of us, so I will take the liberty of asking you and Dr. Nagesh also. How do you rate bariatric surgery versus oral obesity new drugs? Dr. Bhaskar Reddy gave a good presentation about it. I think few people have joined late, so they wanted to, yes, sir, your comment, and then I'll ask Dr. Nagesh.
I think it's individualized. So, each has got its advantage. A lot of them don't want to go to surgery. And it doesn't mean just because they've had surgery, then they can get back to their old life. There are a lot of counseling is required. It's not that after surgery, they can just relax and keep doing what they were doing before and get back. Oral drugs do have an advantage right now. And I think in many cases, it's able to meet the requirement of bariatric surgery. So I think it's an option we have to give it to the patient. And of course, if it's grossly morbid obesity, I would still think bariatric surgery is especially when there are so many comorbidities, I still think bariatric surgery will score over oral obesity drugs or injectable also for that matter.
Thank you, sir. Dr. Nagesh.
I think we need to take 3 points into consideration. One is the safety. Oral drugs are definitely much more safer than bariatric surgery. Second is, and weight regain is an almost certainty with bariatric surgery. Nowadays, we see most of the bariatric surgeons after surgery or even prior to surgery starting people on GLP-1 agonists because they need to maintain the weight loss. In fact, till a couple of years ago, this was a soft contraindication in bariatric surgery. People in bariatric surgery were actually not supposed to be on GLP-1 agonists, but now in the recent guidelines, that has been modified slightly. Second is the availability. As newer and newer GLP-1 agonists become available and obesity-lowering drugs like tirzepatide and retatrutide, which will be available in the next 2-3 years, the amount of weight loss you get with this is almost 40% in clinical trials, which is identical or in fact even slightly better than what you'd see with a bariatric surgery. And the third part is looking at the side effect profile. All bariatric surgeries do have some amount of side effects. In fact, that was the reason why we started going ahead with restrictive procedures as opposed to malabsorptive procedures, because the risk of nesidioblastosis was higher with the malabsorptive procedures. Even some of these newer anti-obesity drugs have had some signals about depression and suicidal ideation. We need large-scale data, but at this point of time, given the kind of response we've had in the West, obesity drugs do appear to be scoring over bariatric surgery for the convenience, the safety, and the fact that they are non-permanent. No human being likes permanence. They don't like a part of their cut being cut or restricted. But like Murthy sir has said, in the short term, if you got very quick response, you do not have an option to bariatric surgery. It has to be an individualized decision based on the comorbidities and the extent of obesity. And not all people will respond to anti-obesity medications, but almost all people will respond to bariatric surgery. That's one point in favor of surgery.
Yeah, thank you, Dr. Nagesh. It is actually even more than the, I would say, physicians or endocrinologists, the surgeons are using GLP-1 also before their surgery to see actually how many are responding, and then they are more, I would say, comfortable doing in the ones who are responding. So definitely it is a big bridge to cross. Earlier, there were not many options available, but now even oral and plenty of injectable drugs are going to come, which are going to further widen this bridge of reaching a surgeon before actually requiring.
And another point is it's not a short-term therapy. It has also oral drugs also have to continue for a long time. That is also another issue. We don't know how long they can continue and what are the issues that will come. It's not just taking for a year or two and stopping. They have to just continue with it.
Sure, sir. There are no further questions in the chat box. Thanks to all the speakers for sticking with their time and then giving excellent inputs. And I thank Dr. Aniket, Dr. Nagesh, and Dr. Siddharth for an excellent overview. And thanks for giving me an opportunity. I hand it over to Murthy sir for further final comments.
So before we finish, one question to all the doctors here. How many of you are actually using AI in practice?
Not much.
Yeah, not really.
Dr. Sree Nagesh, after after listening to you, all of us have got a little frightened also.
The practice.
I'm very frightened of AI, especially about the lying part. We've seen this a lot. AI is very human, actually. At least as far as lying is concerned, it has approached humanity. It has already crossed the Turing test as far as lying is concerned.
The hope we had that it cannot replace natural intelligence, and we are only hoping that it can complement human intelligence. But as you said, yes. But it is once you have let it free, God only knows the limit. I think it's a double-edged weapon. There is something to also be scared of. It cannot it can become a Frankenstein also. It can become a Frankenstein also.
Something that a very important point that Dr. Ganesh made. The utility of AI is very important, determined by the kind of prompts you give it. And that enables us to use it to our advantage. So while it might be frightening, but it is a very useful tool, believe me, in diagnostics, in research, in And it's not just about intelligence, it saves you a lot of hard work and time. So, we need to use it to our advantage intelligently. I mean, natural intelligence should supersede artificial intelligence.
And as you mentioned, technology has to be properly used. Technology has its pluses and minuses. It's a question of how you use it and how you resource it. So it's everything is got. So technology also has got a plus and minus. If you use it in controlled situation, as you said, to complement human and natural intelligence, yes, it can definitely be of benefit.
If you actually look at genetics databases, many a time we actually had a problem fitting in clinical features to a genetic syndrome, especially we get a lot of this in endocrinology. Nowadays, if you go on to OMIM, which is powered by Google AI search, and you type in most of the clinical features, you'll get 3 or 4 near hits on the genetic diagnosis. I've seen this in a lot of syndromes. And when you actually do the exome sequencing, it will end up being one of the 3 possibilities which is raised by the AI-assisted Google search. This is one area, especially this is actually being used in remote tele-learning as a method of diagnosis by paramedical workers. But again, that can be very dangerous in the long term if not properly used. It can give you a diagnosis. Many a time it will actually beat a doctor in giving a diagnosis, but harnessed properly.
What about patients using artificial intelligence to check up on the doctor?
They're already using it, sir. That is where we get all these Google queries. So the best thing we can do is put AI to answer their Google queries.
AI versus AI.
AI versus PI, patient intelligence, which is always better than AI.
Yeah. So now, thank you very much, Dr. K.V. Harikumar, Dr. Aniket Vijay, Dr. Sree Nagesh, and Dr. Siddharth Lakahani for that excellent session. Very interactive, lot of information, thought-provoking, and after 3.5 hours, still being able to listen to speakers really talks much, because it was so interesting, and the tempo was maintained and so many useful interaction. I've also been asked to summarize or give a short synopsis. I'll start by saying, it's nearly 4 hours, and everyone should be exhausted. Everyone should be mentally also tired and looking forward to lunch. But I'll make it as short. And as you'll all understand, with so much of information being interchanged, such excellent talks, innovative ideas, interaction, I would not be able to do justice. But just a short synopsis, certain points which I've noted down. In a couple of minutes, I'll finish. Module 1, moderator was Dr. Ameya Joshi. The talk was by Dr. Subhash, Chandra and Select Trial. New look at glycemia, inflammation, and heart failure. The emphasis was on the use of the molecule semaglutide, especially in those who are obese or overweight without diabetes, with cardiovascular disease prevention. And what was emphasized is we have now gone off from an era of glycemic-centric therapy much beyond. And what has been shown was with body weight reduction, not only glycemia improves, cardiovascular benefits are also achieved. The next talk was by Dr. Rana, Bhattacharjee, newly diagnosed type 2 diabetes mellitus. What should be the focus of management in 2024? Again, we have moved on from the era of glucose-centric therapy to a more holistic management. Obesity has taken off in a very big way, and obesity management is the key, because that can also optimize diabetic control. And again, the emphasis was also on preventing complications by various factors of not only weight control, blood pressure control, lipids, and glycemia. Various modalities and different trials were discussed to emphasize this point. Next coming to the third thing by Dr. Sree, Bhushan, Raju, acute kidney injury and its long-term consequence in diabetes. Acute kidney injury and long-term consequence in diabetes was discussed. It was shown that diabetes makes an individual prone to acute kidney injury, and various strategies were explained which could prevent AKI moving on to CKD and end-stage renal disease. And sometimes an innocuous molecule like proton pump inhibitor also could be responsible. That was discussed. Now coming to the second module moderated by Dr. Sanjay Bhadada, the first talk by Dr. Vijaya, Bhaskar, Reddy, strategies for obesity and diabetes, new insights into therapy. Novel agents were discussed. The first one was agonist, dual agonist GLP-1 and FGF2 21, where GLP acts on the brain and pancreas, whereas the FGF2 acts on the liver and adipose tissue. So each complements its action. Second was an interesting molecule which is in the pipeline, HS235, because this is one molecule which is able to prevent lean body mass loss while reducing fat, because all other drugs mainly, not only they lose fat, you also lose some degree of lean body mass. Then there were also other drugs, one amylin and trisulfide combination. They're all in the pipeline and hopefully they'll be useful in the time to come. Dr. Blessy Sehgal, she talked on the vascular crossroads, hypertension and vascular disease in DKD. She discussed a whole lot of DKD phenotype, novel biomarkers, disease classification with molecular target. And all this would be helpful in treatment strategies so that you could treat individuals with precision. It's not that one size fits all. Then coming to the third module moderated by Dr. K.V. Harikumar, beyond statins, evaluating and treating residual atherosclerotic CV disease risk by Dr. Aniket Vijay. New lipid-lowering therapeutics in diabetes. Non-statin therapies were discussed, estimate, mefenic acid, inclacin, HAL2, GLP-1, PCSK, and importance of lipoprotein small a therapies were discussed. Advanced diagnostic imaging like stress testing, CT angio, coronary angioscope, and a whole lot of this were also discussed. Coming to diabetes, technology is changing diabetes care in the real world. A very thought-provoking talk by Dr. Sree Nagesh. So AI in health in general and diabetes, various areas like pertaining to therapy, pertaining to diet, he could explain. And he also talked about the comparison, artificial and human intelligence. It's a question of whether we will be able to rein in and control, and most important, complement with natural and artificial intelligence. So any very thought-provoking lecture, and only time will tell whether we have reason to be scared or we could use it to our advantage. Then finally, we had one on heat waves and kidney, global warming, various areas we are scared now of, and Dr. Siddharth Lakani could also explain pertaining to nephropathy, how heat, hydration is very important, and also the effects of vasopressin as well as vasopressin may be required. Vasopressin estimation could also be used in this area. Now, having finished this, I'll come to the most important task of a thank you. So starting with Dr. Amit Bhargav and his medical team at Corona Remedies, it is no small matter to have done this. A whole ADA meeting has been, I'm sure you would have gone through this in multiple times, you would have shortlisted, and finally coming up down with 9 talks, which was of benefit to the Indian population, and then looking at the Indian perspective and also getting this done. I think it's a Herculean task. A big thank you to you. And it is because of this that not only the speakers, the faculty and all this, it was excellent talks, thought-provoking, tempo maintained, lot of interaction, very useful factors thing. It's not easy sitting through 4 hours of any meeting. I don't remember when last I did it, but we could still do it thanks to all the effort you put in. And then it is not only there's so many logistics, other organization and the passion and hard work being put in by Mr. Vijaya as the head, Mr. Jayesh Mas, Mr. Tushir Tohi, and Mr. Ronak Agarwal. Thanks to all your efforts and hard work that made us have a wonderful program, lot of learning, lot of issues raised, lot provocation. And for me, it's been a learning process throughout. Thank you so much for inviting all of us to be part of this very, very interesting meeting, and over back to the organizers.
Thank you very much, sir. I'm handing it over to Mr. Vyas.
Tushar, please.
Thank you so much, sir. And thank you, first of all, for sparing your time for making this Deciphering ADA a super successful program. My sincere thanks to Murthy sir for chairing and being the co-director. The entire session was full of clinical pearls, and the panel discussion was also just like a melting pot, which had a lot of clinical insight that can be applied by the clinicians who were our viewers. So with this, on behalf of Corona Remedies, we sincerely thank all the moderators, speakers, and obviously Murthy sir for making this Deciphering ADA a super successful program. And we promise you to continue and provide you all such type of platforms to continue with scientific piece in future as well, and further improve the topics as well. And with this, we would like to conclude the current session. Thank you so much and have a nice Sunday.
Thank you all so much.
Thank you, sir. Thank you. Good day, everybody.
Same
Thank
to
you,
you.
everyone. Thank you, sir.
Have a wonderful and relaxed weekend.
Thank you, sir. Thank you. Bye, all.
Thank you, sir.